Okay, morning everybody. We'll go straight into the meeting. I think we've got quite a lot on the agenda today. And as you can probably see by the agenda, it's timed. So I want to try my best to keep it running smoothly and keep to those times if at all we possibly can. So officers that are producing reports, we've all read them, that's on the committee anyway, so you just need to give us a brief pre-say of it, and then we'll go into questions if that's okay. And if you can all introduce yourselves as well before you produce the report. So we'll go into substitutes and apologies. Do we have any?
Apologies from Councillor Andy Soloway.
Hugh, any members' interests to declare? Nope. Admission of the public. It is not recommended that the public be excluded from the meeting for the consideration of the items of business on this agenda. Public deputations, I understand we've got two. Is Jenny here?
She's just trying to get in, Councillor Greenwood.
Okay, do you want to read out the other one we've got?
Yes, I can read out the deputation from Rosemary Hedges, who's putting it from Caldown Kirklees 99 call for the NHS, who's put a deputation but is unable to attend. So I'm going to read out the deputation now. It's not very long. The draft IC Board constitution arrangements for public participation are weak. I propose that the IC Board constitution should strengthen them as follows. 1. Meetings in public. Arrangements for public participation in meetings of the IC Board and any other bodies that it delegates its functions to should be no less than current arrangements for public participation in the non-statutory ICS board meetings and CCG meetings. The IC Board constitution should specify that standing orders of the IC Board and bodies to which the board delegates its functions and powers will include arrangements so that the public may attend IC Board meetings and meetings of bodies to which the board delegates its functions and powers. The public may put questions and deputations to the IC Board and bodies to which the board delegates its functions and powers, both at its meetings and between meetings. At the end of these meetings, the public may make comments about the discussion and response to their questions and deputations. The minutes should document the public's questions and deputations, resulting discussion and oral and written responses from the IC Board and other bodies to which the board delegates its functions and powers. The constitution should clarify what constitutes a public petition to the IC Board and put receipt and discussion of petitions on the same basis in standing orders as public questions and deputations. The constitution should specify any grounds for excluding the public from meetings of the IC Board and other bodies to which the board delegates its functions and powers. 2. Publication of IC Board agendas, papers and minutes. The constitution should say IC Board agendas, papers and minutes will be published electronically and at the offices of the ICB body at least 7 clear days before the meeting. 3. ICB arrangements to consult its population on its system plan. The draft IC Board constitution arrangement for consulting IC Board population on its system plan, paragraph 9.2, are inadequate as a means of involving the public in the exercise of IC Board functions. They should be replaced with arrangements that offer a real way of involving the public. The current arrangements are limited to carrying out engagement and involvement activities which may include surveys and focus groups, and an engagement and consultation mapping report which will set out the work that has taken place in our local places and at West Yorkshire level. We have heard from participants in such engagement and involvement activities run by the current ICS that focus group events are like indoctrination sessions. Community assets are increasingly declining to attend, so that apparently now ICS officials outweigh community assets. Community assets have felt compelled to send surveys to their service users because the clinical commissioning groups pay their organisations meagre funding, such as a £5 or a £10 payment for each completed survey questionnaire they receive back from service users. When the right care, right time, right place consultation applied, this method to maternity, sorry, I'll start that sentence again. When the right care, right time, right place consultation applied this method to maternity services, Coaldown Kirklees 999 call for the NHS objected that the public engagement on the proposed maternity services changes was late, rushed and unethical. The online engagement survey was filled in by all kinds of people without the remotest interest in maternity services who wished to support a cash-strapped community group that was promoting the survey in exchange for a £5 payment from the CCGs for each completed survey. And there's a link to that situation. This practice seems like a dishonest box-ticking exercise. It should be replaced with meaningful public consultation on the draft IC board system plan for ICB compliance with local authority health overview and scrutiny arrangements. The Constitution should specify that ICB compliance with local authority health overview and scrutiny requirements includes joint West Yorkshire local authorities health overview and scrutiny requirements. 5. Public lay members of the IC board. The IC board membership and any other bodies to which it delegates functions should include lay members whose role is to represent the public. The Constitution should specify the means by which they carry out this role. And that's the end of that deputation, Councillor Greenwood.
Yeah, thank you for that, Mike. And if we can thank Rosemary for sending this in, and obviously we'll take that into consideration when looking at this issue. And maybe Ian might want to say something about bits of that in your report.
Chair?
Yes?
Yeah, it's Kevin Swift from Wakefield. What Mike's just read, is that the same as the version we had emailed to us? It looks to be the same.
Yeah.
It is. Right, thanks.
Yes, it is. Normally what they do, they'd come in and read it themselves, but unfortunately Rosemary couldn't make the meeting today. But we've got another one coming up now, and that's going to be Jenny, who I just saw log on. I don't know if she's disappeared or not now, but yes, it is the same.
Thanks.
All right.
Yeah, I am here.
You are here. I thought I saw you. Oh, there you are, Jenny. Morning. Okay,
Morning.
so I understand you've got one as well.
Yeah, shall I go ahead?
Please.
Okay, thank you. So thanks for letting me speak. I am speaking on behalf of Calderdale and Kirklees 999 call for the NHS. We think that the consultation on the draft Integrated Care Board Constitution can't meaningfully proceed without the IC Board Governance Handbook, but this is omitted from the draft Constitution and its annexes. The Governance Handbook is to include the terms of reference for all Integrated Care Board committees, subcommittees and joint committees that exercise its functions, including the delegation arrangements. This is about which bodies are to have decision-making roles in NHS commissioning, what the membership and scope of those bodies will be, and how they will be accountable to the Integrated Care Board. Lacking this key information, the consultation should be stopped immediately and only restarted once the Governance Handbook has been published. It should then run for the full 12 weeks. We think it's vital that the Constitution is clear about the delegation of the Integrated Care Board's commissioning functions, particularly given the obscurity of the new provider selection processes that are to replace current contracting regulations and legislation that the Health and Care Bill abolishes. Without clarity on the Integrated Care Board's delegation of functions, the Constitution is a hollow shell, which potentially allows almost anything to take place with regard to NHS commissioning decisions. This is totally unacceptable. We say just look at the arguably corrupt and wasteful contracting that's resulted from the Department of Health and Social Care's black box commissioning of COVID-19 emergency goods and services. So why has the Governance Handbook not been published? NHS England has told integrated care system leaders that they, quote, must now confirm plans to ensure that commissioning functions are organised across the ICS footprint, including apportioning between the Integrated Care Board system level and place level. But the Health and Care Bill does not legislate for Integrated Care Boards to delegate their commissioning functions. So there's a gap in the legislation, and instead, NHS England's interim guidance on Integrated Care Board governance says that legislation for the delegation of integrated care board functions will only be made through Department of Health and Social Care statutory guidance and statutory instruments. That's secondary legislation once Parliament has passed the Health and Care Bill. In a deputation to the West Yorkshire Integrated Care System Joint Clinical Commissioning Committee meeting on October the 5th this year, CK999 challenged the integrated care system for not informing stakeholders in the development of the Constitution that the legal basis for delegation of integrated care board functions does not exist. The integrated care system responded that they were only talking to stakeholders about the process of developing the Constitution, and they did not regard this issue as having anything to do with that process. We disagree. The process of developing the Constitution is highly questionable if it means omitting the governance arrangements for delegation of the integrated care board's functions and then omitting the reason for this omission. Is the reason because NHS England is waiting for the Department of Health and Social Care to produce secondary legislation for integrated care board's delegation of functions once Parliament has passed the Health and Care Bill into law? If so, this is legislation which would completely bypass parliamentary scrutiny. This practice has recently been criticised by two cross-party House of Lords select committees as, quote, government by diktat, and again, a tendency in departments to introduce bills before the underlying policy has been thoroughly thought through. Clinical commissioning groups and integrated care system officials who are writing and consulting on the statutory integrated care board constitution should surely not be complicit with such legislative malpractice. We think that therefore the draft constitution consultation should stop now and only resume once the governance handbook is published. Thank you.
Thank you again for that, Jenny. Again, that might be, Ian may be able to cover some of those points in his report.
Thank you.
Okay, thank you. Right, assuming you've all had a copy, if we could approve the minutes of the last meeting, which was the 20th of July. Everybody okay with that? Yep, perfect. Right, so we'll move on to the business item, West Yorkshire Integrated Care Board.
Thanks, Councillor Greenwood. I think Stephen Gregg's going to summarise this item before we open up the questions.
Yeah, is Stephen here?
Yes, he's here. Yes.
Yes. Hello. Can everybody hear me?
Yeah, we can hear you. I just can't see you on here.
Oh.
Oh, there you are. I can see you now. Hi.
Hi. Hello, everybody. For those people who don't know me, my name's Stephen Gregg. I'm the governance lead for the Health and Care Partnership. And I've been working with colleagues across the system to develop the Constitution and supporting governance arrangements. Based on the Chair's comments at the start, I'll obviously assume that everyone's read the papers. I'm just planning to kind of run through the main points of the Constitution and those points where we're particularly seeking feedback on. And I mean, we very much welcome the opportunity to talk about the Constitution with you today. We outlined our approach back in July, and obviously from April of 2022, subject to legislation, ICBs will take on the commissioning responsibilities of CCGs and lead the integration of health and care across the area. We're very keen that our new arrangements support well-established partnership working in West Yorkshire, which is already set out in our MOU, which we brought to you a couple of years ago. And we think those arrangements are helping us to tackle health inequalities, produce better outcomes, for example, through our Healthy Hearts work around hypertension, through the work to identify and support new carers across West Yorkshire, reducing stillbirth and maternal mortality in more deprived communities. We think that it's not just governance for governance sake. We think our partnership arrangements are actually truly helping us to tackle some of these intractable issues across West Yorkshire. So we want very much in developing statutory arrangements, we want to build on what we think works already, keep what works and build on that going forward. And a key part of this is our ICB Constitution. And we've wanted to take an inclusive and participative approach to developing that constitution. The national requirement is that there's a 2-week window to engage with stakeholders. We felt it was important to have a much wider engagement process to share the draft constitution with partners and stakeholders. So we put the documents on our website back at the start of November, on the 8th of November, and we're running that involvement process up until the 14th of January. So we think it's important to hear what Scrutiny and other stakeholders have got to say about the constitution, so that we can build into those arrangements going forward. Having said that, the constitution itself and any changes to it must be approved by NHS England. So we think it's important that rather than having to go to NHS England every time we want to change, for example, terms of reference of a committee or a policy, that we have the flexibility to make those changes as a statutory organisation. So the constitution is intentionally a high-level document, and we will support it with detailed policies around conflicts of interest, standards of business conduct, terms of reference in a governance handbook, which we're not consulting on at present because we're still in the process of drafting all the underlying detail that will support the constitution. But we will publish that on our website, and we will seek comments on that when we get to the point where we're actually able to share that detail with you. So yeah, picking up Jenny's points around that, the constitution is intentionally a high-level document. We've got nothing to hide in relation to the detail that supports it, but we're not there yet with it, and we will share that with yourselves and stakeholders once it's developed. So moving on to the detail, some of the detail in the documents which we've shared. Right at the heart of our approach is delegation to place. We think that our partnership only works effectively if decisions are made closest to the communities which are affected by those decisions. So we've attached to the constitution, to emphasise that primacy of place and our approach to subsidiarity, a functions and decisions map at Annex 2, which hopefully sets out on one page how we see decision making working, with strategy being set by health and wellbeing boards, being brought together at West Yorkshire level by our integrated partnership, which is currently our partnership board, and then with the delivery of that taking place either at system or place level, depending on the nature of the matter. We've attached a high-level scheme of delegation, which again sets out those areas where that we think will be reserved to the ICB board, and those where we expect place-based committees of the ICB to take decisions, and a governance structure diagram which seeks to just provide a map of how those things will work together. We've also attached to Annex 5 our governance standards, which summarises some of the things which are in the constitution, which I think are intended to pick up some of the points raised in Rosemary Hedges' points around transparency, independent challenge, meetings in public. Absolutely, we're committed to that, both at ICB level and in the committees where we'll do to which we'll delegate some of that business. So absolutely, we see it as running right through our arrangements, that those should be open to members of the public. We welcome questions, we'll publish the papers online, and we'll publish minutes and responses to questions online. Obviously, place governance structures are key to our approach. They'll only work if we've got strong governance systems at place, and each place is currently discussing exactly how that will work for them within the context of those good governance standards. So we think it's important that place-based committees reflect the local needs, the local arrangements in place, but within the context of a set of agreed governance standards around transparency, independent challenge, probity. So that's the broad approach that we're taking. So in the introduction, we've sought to put the constitution within the context of how we already work in West Yorkshire, drawing on our partnership MOU, setting out, as I say, the key role, the absolutely key role of health and wellbeing boards in setting strategy at place level, which is then brought together at West Yorkshire level through our integrated care partnership. Then go on to some of the detail within the constitution, starting off with board composition. We think it's important to have an inclusive board, bringing perspectives from right across our system. We have an independent chair, but we propose 3 independent non-executives, which will have a broad range of portfolios around accountability, quality, people, citizen involvement, and future sustainability. The board will bring together the perspectives of NHS trusts, primary care, local authorities, the voluntary community sector, Health Watch, public health. It'll have clinical input through a medical director and a director of nursing. That gives us with a board currently of 21, which is larger. That we acknowledge that is larger than best practice would suggest around effective boards. We've sought to balance that effectiveness question against the principles of inclusiveness that are important to us as a partnership. The bill sets out that elected members cannot be members of the ICB board, but our proposal is that the chair of our integrated care partnership, our partnership board, although they won't be able to be a member of the board, they will attend the board and be able to contribute and participate in all the discussions. Next section is around appointment processes to the board, where we've set out our approach to both nomination and appointment. Where appropriate, we're outlining a two-stage approach to appointments, with nominations led by the respective sector. So, for example, the voluntary community and social enterprise sector would lead that nomination process before we then have a rigorous appointment process, which we think absolutely critical to that is that both nomination and appointment processes support our commitment to improving the diversity of our leadership. So we're building that into both of those processes. Section 4 sets out the high-level arrangements for delegating the ICB's functions. I draw your attention there to that functions and decision map and that high-level scheme of delegation that seek to set out clearly the key decisions that we think need to be made at place. So each place, for example, will be agreeing a place-based plan to meet the health and care needs of their population. Each place committee will be allocating resources to deliver that plan in place. And each place will be arranging for the provision of health service in line with those allocated resources. We propose, in line with that delegation, that arrangements for the scrutiny of ICB plans and decisions should align with that scheme of delegation and reservation, with, for example, West Yorkshire level matters being scrutinised by this group and place matters by the relevant place scrutiny committee. Section 5 of the Constitution sets out our procedures for making decisions, and then that links to the standing orders which are attached to Appendix 2. Section 6 sets out our arrangements for managing conflicts of interest and standards of business conduct. These are obviously going to be absolutely key to these new ways of working. So we've set out in our Constitution our high-level principles that we want to apply, and they will be supported by detailed policies, as I say, around managing conflicts and standards of business conduct. Section 7 sets out how we propose to ensure accountability and transparency across the system. And as I've already mentioned, so that draws out important principles like arrangements for holding meetings in public and publishing papers, arrangements for ensuring that independent challenge is built in at each level of the system, including complying with local authority overview and scrutiny requirements. The section also includes our proposed approach at this stage to combine with the provider selection regime. The further details that will be included in a separate policy, and that will need to reflect the regulations around the provider selection regime once they've been produced by the government. Section 8 sets out how we're going to approach terms and conditions of employees, including the establishment of a remuneration and nomination committee. Section 9 sets out our principles for involving people and communities, and involve links to our detailed plans and involvement policies, which you'll be familiar with, which I believe have been brought to earlier meetings of this group. And Appendix 2 sets out our standing orders, our arrangements for making decisions, which we believe are based on sound principles of governance good practice. So, conscious that was a fairly rapid run through what's quite a large document, highlighted some of the issues. We're positively encouraging comments from stakeholders during the involvement process, but obviously welcome comments, questions on any aspects of the arrangements that we've set out there.
Yep, that's great. Thank you for that. I don't think I'll ever get used to the word place in this context, but anyway, that's a decision that's been made. Obvious question from a councillor. Why can't elected members be on the board?
They're part of the Elected members are one of the prohibited groups around. It's set in the national legislation. There's a range of prohibited groups, including members of Parliament, local authority employees, local authority elected members. So they're one of a large group of restricted restricted groups in terms of ICB board membership. The same held for CC membership of CCG governing bodies.
What's the rationale, though? What is the rationale? Because surely
the rationale is largely around political involvement in.
Oh, we can't have that, can we? Anyway, that's a decision that's been made, so it's not a lot we can do about it, but it doesn't make any sense to me. Councillor Hutchinson.
Thank you, Chair. I do have several questions, I'm afraid, but I'll start with the first one. I mean, we do need to recognise that there's going to be huge amounts of public money flowing into this integrated care system, and it is essential that there are watertight governance measures in place to give the public the confidence that this money is being spent in the right places and on the right things. But much of this commissioning is going to be performed by committees and subcommittees of the Integrated Care Board. And the bill contains very little detail of how these committees and subcommittees will work in practice, including terms of reference, except that their minutes will be published on the Integrated Care Board website. It's quite right that we've asked to be involved in this process at a formative stage. So I recognise that it's been said that it's not there in statute, it's not there in the commission, it'll be in the governance handbook. But I would suggest that we can't say that we have consulted on the Constitution without seeing the governance handbook and being able to debate on that. So I would hope that this is not, at the end of today, we're not going to say, yes, all well and good, this is done and dusted, no need to look at it again. I do think we need to be reviewing this once a greater level of information is available to us. But given that this is, so I would make that plea, but given that this is a high level document, I was surprised to read that the vision of West Yorkshire Healthcare Partnership is set out in clause 1.1.15, that there was no mention of that vision being the provision of a comprehensive health system to the people of West Yorkshire. So I was wondering why that isn't a key part of the vision. And section 1.3 defines the area covered by the Integrated Care Board, but I can't find any definition of the people for whom the board has the duty to procure the provision of health and care services. And I don't think that's a hypothetical issue. On September 28th, the Manchester Evening News reported that a woman suffering from agonising burns was turned away from 2 NHS units because of a protocol put in place by Northern Care Alliance that restricted the geographic area of Greater Manchester from which they would receive patients. What in this constitution would prevent such a thing from happening here? Similarly, my sister lives in Essex. Let's suppose that she comes to visit me over Christmas and develops acute appendicitis, or maybe next Christmas, the Christmas after this. Will West Yorkshire Healthcare Partnership treat her without any question at any of the hospitals in West Yorkshire? I do think we need to have that clearly stated so that people will know who, is it everybody who happens to be in West Yorkshire that will get care from West Yorkshire Health and Care Partnership under the new arrangements? Or will there be restrictions in the people to whom that care is available?
Who was going to answer that? Ian?
You want me to come in on that one? Yeah, I'm happy to. Do you take them one at a time? Okay, that's thanks very much, Councillor Hutchinson. Really helpful questions there. As you rightly point out, that the place arrangements are critical in this, and it almost links back to the point that Rosemary made in her deputation around, we want arrangements that are no less transparent than what we've got now, and the transparency and ability to scrutinise those place-based arrangements are really important, and we'd expect those meetings to be held in public, papers to be published 7 days in advance, have the right level of non-executive input into those place-based committees as well. So that's absolutely something that we're working towards. I think your point about the handbook is well made. As Stephen said, we're working through that next layer of detail now. That will be we'll be engaging and working with partners on that, as we have done with the Constitution, and we can arrange a conversation in the new year to consider the detail in that. What I would say is that the scheme of the high level scheme of delegation that Stephen included as part of the papers do give a decent indication of where we think things will fall in the future, recognising that further detail is required around those things. In terms of the point around comprehensive health system, commissioning of a comprehensive set of health services in the vision. The vision was taken from the previous kind of ICS documents, but I think, and we would kind of almost assume that was taken as a given, but it might be helpful to be a bit more explicit about that. So we can be a bit more explicit about that as we develop the document. And in terms of the areas covered, I think that would apply to all people who live in West Yorkshire and Craven in this case, but we can again check on that and make sure that we're clear on that point. What I would say is it's really helpful to have this kind of feedback. We've got between now and the middle of January, we are engaging on this document for exactly these kind of reasons. So it's really helpful to hear this stuff now.
Sorry, Ian, it's probably worth adding. Sorry, hello everyone, my name's Rob, I'm the Chief Exec Designate. I think behind Councillor Hutchinson's question on area was a concern that people might be turned away for emergency treatment if they didn't fall within our catchment, and there's absolutely no intention of that whatsoever. The same arrangements would apply as apply now.
Will it be possible to actually state that in the Constitution? Because it seems odd to cover area but not people.
Yeah, I guess it's the kind of if we think about planned care and the duty on us to ensure that we make sure that people can access services where there's a planned need. You're waiting for a cataract operation or whatever. You wouldn't expect us to arrange your sister in Essex's cataract operation, but you would expect us to do that for everybody who lives within the boundary.
Although there might be good reason for doing that, maybe not necessarily for cataract, but if somebody has family support, to facilitate their recovery.
So if there was some kind of degree of somebody choosing to have some kind of procedure close to their family, then certainly that's something to consider. But if there's a concern that what we're doing here is creating something whereby citizens wouldn't have access to things if they weren't a local resident, that isn't the kind of arrangements that we're setting up here.
No, I just think it ought to be specified. We don't want people falling through the cracks.
Yeah. So if we can take away, some things that are a given that we could put at the beginning around, what's already in statute, which continues.
Okay, Councillor Hutchinson. Councillor Smage, next then.
Thank you. As to the places on your board, I think there isn't a lot of mention of scrutiny, and I think it would be quite interesting if scrutiny could have an observer, be an observer at the board. But there you go. That's just my opinion. In relation to the board, you've got various positions that you've outlined in your Constitution. How are you going to ensure that there's a coverage of places in the board, so there are voices from the different places on the board? Because you've said which people will be eligible to apply for those positions, from which organisations, but I can't find anything that would give you a coverage across your place for voices. What is to stop all the voices being from one place? Just is a concern about that. And you also say about in your 1.1.3, you've got to achieve a critical mass beyond local population level to achieve the best outcomes. I just want to explore for a minute what you mean by critical mass and local population. Because I can see the straight lines between place and the ICB. I'll get on to delegations in a minute, but I can see the straight lines there. But I can't see anything that would allow 2 or more places to come together where services were only across several places. So if you're talking about service reconfiguration, for instance, that is across 2 or 3 places, or service provision across 2 or 3 places, then how are those places going to come together to look at those services? Is it purely at West Yorkshire level, or will there be some delegations across? I'm particularly thinking of services across Calderdale, Kirklees and Wakefield, where there are more joint services between 2 or 3 of those places. And how is that going to work? If we take things that have happened previously, I haven't got a sense yet of how any hospital reconfiguration, where that in actual fact decisions would be taken. I just can't see that in these documents. It just is not clear at all. And it is not clear as to whether there is acute or reconfiguration of acute or any other services, as to if somebody in that particular body is on your board, whether they have a part in the decisions. So for instance, if the acute trust is reconfiguring and that acute trust is on the board, then does that acute trust still have a vote in those decisions? I just don't see that at all. I also don't see any relation to do we still use the term tertiary services, where there are services that are commissioned elsewhere, and how the ICB will feed into anything in relation to that. And on your delegation appendix, you've got things like, you've got agree joint work on estates, procurement, supply chain, etc., etc. And then you've got the same text, but you've added the words in place. So one's reserved to the board and one's reserved to places committee. And I don't get a sense from this document how that is actually going to work in practice, and where those delegations are, and how, what is for one and what is for another, and how that feeds in, etc. Now, I realise this is just a high level document and we're going to need more. Maybe the governance handbook will have this in, but it just doesn't, for me, I'm not getting a sense of how that is going to operate in practice. And therefore, I think it's a little difficult to say, is this a document that's fit for purpose on the higher level? Because I can't see where the practical is going to come in. Thank you.
Steve, have you got your hand up to respond to that?
Yes, I mean, I certainly respond to parts of it. Maybe that Ian and Rob might come in for other parts. But in relation to the representation of place on the board, you're absolutely right. It's key that we get the perspective of each of our places, and that's why we've established specific representative from each place. So we can't have you wouldn't have the situation that you've got no representation from Calderdale or Kirklees or Leeds or whatever, because we've built into that board structure explicit place representation.
Sorry, yes, I was meaning your definite things, like you've got an acute trust, you've got a director of nursing, you've got a health director of public health. Those definite positions, I was referring to those. Sorry.
Yeah, well, I mean, we've sought to set out that kind of principle of balance, that we want to have a balanced board. Yes, we want to have explicit membership representation from each place, but we would seek to ensure that there's a broad representation across the range of members on the board. In terms of your point around critical mass against local population, I mean, that's drawing on our existing practice of only doing at West Yorkshire some things that meet those three tests of working across West Yorkshire, and building from place upwards to deciding whether we want to work either at West Yorkshire or across one or more places. So the whole of our approach to delegation is built on that principle that we do at place unless there are good explicit reasons for doing at more than one place or across West Yorkshire and Harrogate. I don't know whether Ian or Rob want to say any more on that particular point.
I think that the place West Yorkshire point's really well made, Councillor Smage. I think what in general terms we talk about whether we plan together at place or whether the work happens at West Yorkshire. I think there's clearly variations within that, and the ability to work effectively across Calderdale and Kirklees, or Calderdale, Kirklees, Wakefield, or Leeds and Bradford, depending on the issues. That's something that we can't rule out by moving to this place West Yorkshire construct. That's really helpful. I think we can ensure that we capture that, as we're developing this.
Yeah, I think that's exactly right. So there are arrangements now where people work together on different footprints. Councillor Smage will be aware of the, Calderdale and Kirklees working closely. I think Calderdale and Bradford work together very closely on things. Bradford Airedale work together very closely on some things. So we probably just need to be a bit more explicit on that. And then the scale point, I mean, I'm sitting today in, just across from the secure mental health unit here in Wakefield. So we wouldn't want to, we've only got one, we'd plan that at West Yorkshire level, community mental health services planned and delivered in each place to meet the specific needs of the population. So in all of this, we're trying to maintain the ethos that we've got, which is, based on the principle of subsidiarity, do as much as possible, as close to the person as possible, as close to the neighbourhood as possible, as close to the place as possible, and then only at West Yorkshire when required. To the point of where ICSs have to work together to think about services which are planned on a bigger footprint, we'll need to make sure that's appropriately reflected. We do have 4 integrated care systems in North East Yorkshire and Humber, and there may be some services, certainly some services that Leeds provides for people outside of West Yorkshire, for example. So we have to have arrangements where those things can be put in place.
Yes, so the question about hospital reconfiguration then, where does those decisions under this constitution lie? Is there the ability then for 2 places to come together, like the CCGs come together at this moment in time and form a committee and make decisions? Then does it have to go up to the ICB? And if the ICB has somebody from that body that is reconfiguring, do they take part in the decision or don't they?
Stephen, do you want to come back in on that one? You've got your hand up again. Oh, is that an old hand?
That's an old hand. I'm happy to comment on that, but that was an old hand.
Do you want to comment on that first, or do you? Yeah.
Yeah, I think it's about making sure we can't, within the Constitution, cover every. I think every possible combination of decisions at an individual place level, a decision affecting 3 places or perhaps all places in the Constitution. But I think that the principle that we start with place, and then depending on the nature of the decision being made, we then make sure that decision is made at the right level. I think that is built. That's kind of a central part of how we've constructed our decision-making arrangements. And in relation to who's involved in those decisions, we're very clear that the principle of both board members and members of committees in place, they are not there to represent their organisation. They're there to bring the perspective of acute trust, for example, local authority. So we don't have a member on the board who is there to represent a particular local authority or a particular trust. They are very much there to represent the broader perspective of that sector. Now, that's not to say that won't present very real real questions of conflict of interest on particular decisions, which we will have to manage on a case-by-case basis. Of course, we recognise that having providers around a table means that there will be conflicts of interest, but we'll be putting in a series of safeguards to make sure that we manage those effectively. We can't avoid them, but we can manage those effectively, I think.
Yeah, I think my point is that you've got straight line governance here in your governing body, this document, but you haven't got anything that allows delegation across several places. And I think this is not in, I couldn't find it in this document. And if this is a higher level document that everybody's going to refer to in the future as to how you operate, surely you need that ability to do that in this document. I think those are my points. And you need to know about conflicts of interest, because those are mentioned in this document as well. But other people are waiting for questions, so I'll leave it at that. Thank you.
I just wondered, Councillor Smage, if it'd be worth us either here or in the handbook putting some examples of how things might work in practice. I mean, we've been thinking that through in terms of the development of the Constitution. Clearly, if you can create a committee in place which has delegated authority to spend money, make decisions, make choices, it's got a requirement to engage appropriately with scrutiny and with the population, everybody else, then those committees could come together to, as they have in the past, to do joint decision making. So I think we can work through some examples with you if that would be helpful. But your general point's right. This is about creating some pieces that you can then put together in different configurations if you need to. And you know, what I would want to be unquestionable is that our commitment to engagement, to working with scrutiny and with others is embedded in all of these arrangements.
Okay, thank you for that. So we've got Councillor Swift, Councillor Rhodes and Councillor Clark, and now Councillor Hutchinson. So we've got 3 minutes if you want to stick to the agenda. I think we're going to blow that now. So Councillor Swift.
Right, it's a comment rather than a question, and it goes back to the issue of public engagement. And it was simply to comment that there is considerable unease amongst people in Wakefield who are involved in different capacities in public engagement at the current state of affairs revealed by the Constitution, at the lack of a firm basis for public engagement, and some of the difficulties that follow on from the fact that the powers at different levels are not clearly defined. So if you're going to talk to somebody, you need to know what clout they carry. So quite a lot of what was actually being conveyed in the Calderdale and Kirklees deputation, quite a lot of that is shared by people who've been involved in public engagement over quite a long period. Thanks, Chair.
Yeah, thank you for that, Councillor Swift. Councillor Rhodes next.
Thanks, Chair. I'm not going to go over what's been said because I totally support the comments that have been made by our previous members here today, including all the issues that Colin and Liz have identified. I'm going to go back to some of the issues that have been raised and some of the answers that have been given. First of all, yes, I do recall when this first came up in shadow, elected members were in awe of, shall I say in awe, so I don't know, they were actually wondering why we weren't allowed as elected members to be on the board, but obviously we know why now. One or two things, if I may. First of all, the implementation of the ICS is due in April, I understand. And yet now we are here discussing that in terms of the Constitution, in terms of the handbook, we will. I want to know what the time frame is, please, because I'm going to go back to Councillor Hutchinson's, to Colin's remarks. I do hope, and it's minuted, that this meeting today is not confirming anything about the situation that we've discussed in terms of the Constitution and the handbook that has yet to be delivered, because that would be a huge mistake. Secondly, I want to know when it's going to be ready for this committee to actually have sight of it, and therefore be able to comment further in terms of the missing detail that's been mentioned already this morning. That's number one. Number two, my colleague, Councillor Swift from Wakefield, has mentioned about the consultation, and it's now running until the 14th of January. I would like to know, as an elected member in Wakefield, and I'm sure others may have the answer to that I don't, where was this publicised in terms of quote unquote consultation? Over many, many years, the point has been made by our lay people and members on our committee, and I'm sure on others, that not everybody is IT literate. So I want to know where, in terms of other posts out there like libraries, community centres, etc., has it been published that there's a consultation going on? That's the second question. I was dismayed to hear actually a response to Councillor Smage saying that it's not possible to cover all things within the Constitution. That makes me very, very worried, very worried. Because unless you have a flexible Constitution, which I don't know about yet, then if it's not remedied now and put in place now, I feel that there's a lot of democracy in terms of the Constitution that is not being seen as open and transparent. And I don't think that that's a statement that's really a credit to anybody at the moment in terms of what we need to do. The issue that Councillor Smage Liz has mentioned in terms of place, I still say whoever got that name really ought to be going to Rob for some therapy. I think that's really important, very, very important. And the accountability local is equally as important. And that's got to be maintained in the lines that Liz has identified. The Health and Wellbeing Board has been mentioned in terms of it being a representative of various places, as I understood, to be on the board. And we know that the limitations of the Health and Wellbeing Board in itself, but nevertheless, it is there in terms of an informative nature and in its role as preventative as well. I think there's a lot that's missing here today that's been identified, Chair. And it's important that we get a timescale on everything that's been brought up here today, because what we don't want as a joint committee, and certainly from our local place committee in general across the patch, is to find out that any changes that we would want to recommend would be timed out. I'll be as polite as that. And I think it's important that everybody realises that at this point in time, there are various concerns about the financial implications, how money will flow to place, and what would be the criteria in terms of how that's going to be devolved, shall I say that, devolved to place. I think there's some questions there that we need answering, and I think those are the vital bits of information that's got to be followed up from today. I would suggest, Chair, that pending the answers we get today, that we put a timescale on getting some of these questions answers back to the Joint Committee as soon as possible, so we can then decide a way forward. But the timing of everything on this is so dependent that I am worried, very, very concerned, and supportive, I have to say, of the two deputations we've had today and their concerns, that if we don't act now, or we get the answers now, and I cannot believe that we're still hanging on an edge in December coming up with the implementation in April, that we will. I was expecting something that would be saying it's timed to be finished and concluded I don't even know what you're going to consult on when you can't answer the questions that we've asked here today and what's missing in the document. So I think, Chair, those are my points following on from everybody else's today.
Thank you, Councillor Rhodes. I don't know who's going to answer those, but I understand there were the three options about what you were going to do: implement it in April, delay it till May, and then I don't know what the third one was, but maybe Rob, do you want to answer that?
Sure. I think the important thing for us is to make sure that we engage appropriately, that we listen, and that we make changes. And there are several things that we mentioned today which will be picked up in the next iteration. I think Ian and the team made a commitment to, as the handbook is being written and developed, we're trying to make sure that what we write isn't a foregone conclusion. Here you go, here's the answer. It's co-produced with people. That takes time. It'd be much easier for us just to write something and say, here it is. That's not what we're doing. So I think what we've said is in January, we should have another conversation if people are happy with that, to pick up some of the questions that have been asked today, for us to then, go through some of the handbook detail. I think the point about we're trying to write something which doesn't have to specify every minute eventuality, which may differ in each place, because we'd end up with a constitution which was huge. And I do think that that point about being really clear about the things we have to be clear on, being flexible around places where we need to be flexible is important for us to hold on to. So I think what we're saying is it's really important meeting for us today. Let's pick up the points. Let's reflect back the changes or amendments that are made as a result, or how we're addressing concerns that have been raised. And let's have the meeting in January to go through some more of the detail, if people are happy with that. I think the intention, we're working at the pace prescribed through the progress of the Act through Parliament. The expectation still is that we should be implementing something on the 1st of April. And if there are delays, then we have to have a contingency plan for that. But from where we're sitting, we're going for the 1st of April, and we'll continue to work with you as closely as we can to make sure we get it right.
Thank you, Chair. Can I then just ask Rob and fellow members here today, the contingency plan, I'm really glad that I didn't bring out the dates myself. In terms of delays, what is plan B then? Have you a plan B on the table?
Well, we'll need to work through that, won't we? We've got existing arrangements and they continue, I think, is plan B. Unless there's a legislative change, then we're carrying as we are. I think the thing that we need to make sure is that all of this is managed in such a way that it doesn't stop us from doing the real work of joining up services, managing the pressures that we've got through the winter, making sure we have a strong and stable social care system that supports people in communities, and making sure that everything that we do is in service of improving outcomes for local people. So
I take it from that, Rob, you're hoping the government is going to follow through with some white paper or improvements in social care, which we've yet to see.
Yeah, so we will continue to lobby for improvements in social care as we have in the past, to make sure that councils and providers have as much support as possible. And as social care is a strong partner in the partnership, collectively we're supporting social care to be and maintain its resilience. And I know that every place is having that conversation in terms of what NHS and local government partners can do in Wakefield, Calderdale, Kirklees, Bradford, Leeds, etc. And we'll continue to look at that as we move forward. I know the government's talking about, isn't it, 2 white papers coming out soon on integration and on social care. So we'll see what's in those. And in the meantime, we'll just try and keep on top of all the things we've got control of ourselves.
Thank you, Chair.
Okay, thank you. Just a right quick one. So there's got to come a point where you're going to make a decision as to whether to go ahead with it or delay it. Have you any ideas when that point will be? Because
Well, I think it fits with whatever happens in the parliamentary procedures that are going on at the moment. And we know that there are a couple of areas of contention, aren't there, which people are interested in around widely reported the social care cap and the requirement to, I think there's a lot of support for the requirement to produce a long-term people plan as part of the Act. So it's whether that gets any momentum, and if that gets some momentum, it could delay things, then we'll have to make a choice.
Okay, thank you. Councillor Clark.
Yes, thank you. Thank you very much. And can I begin by congratulating Rob on his appointment? That's very good news for all of us, I think. I'm being from North Yorkshire, and I don't want answer. I know I won't get an answer today, but it's how the Constitution is going to be able to take care of the fact that you will be dealing with another local authority that is not in the West Yorkshire Combined Authority. We've had this discussion before, and I think it's very important that we get these points made in the Constitution so that we can arrange things. We keep talking about place, and one of the places you're dealing with is Craven, which I think is right that it's in the West Yorkshire as far as the NHS is concerned, but it's a very large place and it has very few people, and it's important that these considerations are taken into account. And it's how we react with other integrated care systems. As you know, the rest of North Yorkshire is in Humber, Coast and Vale, which I don't know all that much about, quite honestly, although I've been a councillor for quite a while, but I believe this is a much stronger integrated care system and a much stronger scrutiny committee. So I'm just asking that you publish information or give information about how you will deal with somewhere like Craven, which is a place that has will be responding to the North Yorkshire Wellbeing Board and that sort of thing. There are also other issues such as how do we deal with areas having two different integrated care systems in North Yorkshire. At the same time, we're doing this reorganisation and we're reorganising local government at the same time. And I think we need to give thought to, I'm not sure what's going to happen to some of the people in Wetherby, for instance, who are in West Yorkshire for local government, but part of it is in the integrated care system for Humber, Coast and Vale. It probably doesn't impact on a large number of people, but I think we need to have these things laid down properly or it will cause us trouble in the future. And I think we need to make sure we get scrutiny right as well, because this is a very good scrutiny committee and has done a lot of work over the years, and it's important that we pay attention to it and involve the public in this. Thank you.
Back on that, James.
Thanks, Councillor Clark. So as a GP in Craven and as a commissioner in Bradford District and Craven, I think you bring up highlight some really important points in terms of how we represent our whole place and how that then links in within the ICB. And I think it is about the kind of strong place-based arrangements, and I think we've got a good history of that in terms of working across different local authorities there. And I think in terms of Bradford District and Craven, there's some strong connections with the local authority and across North Yorkshire there, which we'll continue to have. And I know through our place-based arrangements, we're ensuring that that happens so that the health and wellbeing boards are linked, that there are recognising the different kind of needs of our different populations, as you highlight in terms of kind of some of the issues in terms of the geography there. But I would say that some of that is is not new, and that's something that we've managed over the developing of our arrangements across our place. And then it's how important those place-based arrangements then link in with the new arrangements across our system there. So thanks for highlighting, but I would like to kind of assure you, I hope that we kind of strengthen on top of what we're already doing at the moment, but recognise the points you highlight.
Okay, thank you for that. Jenny, please would you mind just turning your video off, because we just have members and presenters on here. It's okay, don't worry. Thank you very much. And now we've got Councillors Hutchinson, Smage and Marshall Katung. And I think Councillor Marshall Katung, you'll be the last one, because obviously this is a really important issue, but we have got two other really important issues to discuss. So we're going to go way over time, I think, today, if that's all right with everybody. So Councillor Clark, do you want to just take your hand down? Is that okay? Then it won't confuse me. And then Councillor Hutchinson next, please.
Thank you, Chair. The NHS is nothing without its workforce. Without the workforce in the right numbers, with the right level of skills and experience, all these aspirations are nothing. I was wondering why there's no committee or subcommittee out of the ones that have been described in the appendix to this document about workforce, with clear responsibility that we are developing and retaining the appropriate level of workforce to make these plans a reality. I was also wondering why there is nobody on the board that seems to be explicitly responsible for social care, because this is, the general public feel that this process of integration is supposed to be integration of health and social care, but the makeup of the board seems to show a great imbalance in this. And then clause 1.1113 emphasizes moving away from simply, and I've put that in inverted commas, treating ill health, to preventing it. Which sections, it's going to take a few years before we've got rid of relative poverty, where everybody is living in warm, stable households and enjoying a healthful diet. That's going to take a couple of years to actually sort out. In the meantime, we're going to be having to patch up people. As Nigel Crisp said, health is made at home, hospitals are for repairs. So I'm surprised that the Constitution doesn't describe or define better the interactions between the health and well-being boards and the integrated care board, apart from the organogram that's in one of the appendices. So I feel those are 3 points at which the Constitution is pretty silent, and would like to see those strengthened.
So I can give a little response to that, and others can come in if they like. So I think, Councillor Hutchinson, I really appreciate you making the point about people. One of my beliefs is that the NHS, the care system, health and care is made of people. It's not the buildings, drugs, kit that make it. It's the people. It's what we spend our money on. It's what we invest in. It's who delivers the care and support. The approach at the moment is that our people board is a programme rather than a committee of the board. So we've got a strong group that's led by a combination of staff from Health Education England, from trusts and from the wider system that come together to plan what staff we need, what our recruitment and retention approaches should be, how we flex our apprenticeship schemes, what we do about training development, digital skills, and so on. And over the last couple of years, we've been looking at how we strengthen that further, working with the Yorkshire universities collectively to create workforce observatory, which looks at how we plan for our future needs into the medium to longer term, and how we develop new roles and skills given, the need for us to work differently with people themselves. So seeing them as partners rather than having a paternalistic approach to medicine, for example, and to take account of the digital world that we now all live in, as evidenced by this meeting today. So that's the approach we've taken, and we've had a bit of a conversation about should we have a people committee or should we really stick with it as a programme. And as we are going to have a chief people officer, somebody who is on the board responsible for making sure that we've got a good people strategy and so on, then we need to make sure that, that might be one of the things that we consider further. So I think it's a really good point. But the fundamental point about people is one that we should all hold on to all of the time, particularly when we're talking about structure and governance. The second point about social care, I think we expect that there's very strong arrangements within each of the places to join up services around the needs of people, involving directors of adult social services, directors of children and young people services, and so on. And at the board, really, we're looking at the place-based leaders picking up the integration agenda, the council representatives doing similar. We know that our directors of adult social services and our directors of children's services work collectively as a group, just as our local authority chief execs do, just as our acute trust chief execs do, and they can play into the way that we work. But it is something we could consider strengthening, again, as one of the points coming out of today. I think what was the third point that you made?
Third was defining better the interactions between health and well-being boards and the integrated care system as a whole.
I think it's a really powerful point. I think in all the communications that we have, we should keep coming back to these are a different set of arrangements for a different time. The bringing together of local government, the NHS, the third sector and communities is all about prevention, wider determinants, as well as healthcare. As you said, hospitals are for repair, home is for life. And I think the arrangements that we've got, we're trying to mirror things, I think, between West Yorkshire and Pless. So in West Yorkshire, you've got the partnership board, which sets the strategy, which the integrated care board and its partners then needs to deliver. And that's built from the places where you have health and wellbeing boards responsible for health and wellbeing strategies, which the place-based arrangements have to deliver. And there's a kind of interaction between those two layers so that we're getting the place-based stuff right, and then we're getting what we need to do at West Yorkshire as a combination of those and what we need to do at West Yorkshire. So we could put some additional material in there. And again, that might be something which councils and Scrutiny will have a particular interest in, because as we've already discussed, the place-based arrangements will be critical to get right and will need to be really effective across that broad spectrum of prevention and delivery of services.
I really would welcome if you look at a people committee, because I do feel that this is, over the last couple of years, things don't seem to have actually moved on. We will be looking at this later on in this meeting, but I do think as a focus, we've got committees for finance, we've got committees for remuneration. I think it needs to be right up there at the top of the concerns, because this is one of the main advantages in bringing people together over a wider footprint, is that we have the scope for growing our own and making sure and trying to get out of this hole that the NHS has dug itself into over the last 10 years or so. Thank you. Thanks, Rob.
Okay, thank you very much for that. Councillor Smage and then Councillor Marshall Cattung. And then if anybody else has got any questions or anything, you can email Mike with them afterwards, if that's okay.
Thanks. So really quick. I wonder if it'd be helpful if you had a communications plan for how you're running your engagement on this constitution at this moment in time. And if we could actually see it, we may not want to wait till January. We might want to have it in the meantime so that we can comment on it in the meantime while it is. I think that's important. we also talked last time about hearing different voices in all of this. And I didn't get a sense from these documents, I think Councillor Hutchinson's picked up on this point, of how you were going to hear those different voices. And I didn't get a sense of how that was going to happen in the future. I understand your points about social care and place, etc. But I think when you're looking at services, it is a whole system, isn't it? Because without the whole system, the different parts don't operate as effectively. And therefore, I think it is important that the whole system view is available when taking decisions. Thank you.
So we'd be very happy to share the engagement consultation plan. As you'd expect, Karen Coleman, who's very proactive, is well on with that. And I think the point about seldom heard voices and making sure that we engage with all communities is really well made as well, Councillor. I hope you can see that in most of what we do, we produce easy read, BSL, video, text versions of materials, which we try and make as accessible as possible. And the benefit of having such strong local government and third sector partners is that we find ways of connecting with all communities.
Thanks, Rob. And finally, Councillor Marshall Khatun.
Thank you very much, Chair. And I echo the words of Councillor Clark and say congratulations, Rob. Yourself and the team, we have met yourselves in Leeds regarding this topic, so I'm not going to ask you too many questions. The only thing I'm going to seek clarity here is, obviously, this is live stream, and we would have ordinary people just listening to us and seeking clarity. You will hear from the rest of my colleagues about that word place. So many of us have said it in different ways, in very simple terms. I'm so concerned that the medical industry is very full, with lots of medical jargon. So for the ordinary man out there listening to us today and hearing place-based term in very simple terms, please shed more light on that for us. Thank you.
Well, I think I think the intention behind it's a good one, which is places where people live and where they feel a connection. So Leeds, Bradford, Calderdale, Kirklees, Wakefield, people understand what they are. So over time, what we've tried to do is make sure that things are planned in places. So where the council is. So CCG's merging clinical commissioning groups to be coterminous with places. So it's just one population, one group of people spending one pot of money to deliver the best outcomes that they can. So we try and do things in the place where people live. And sometimes that's your neighbourhood. It might be, Armley, or it might be Rawdon, or it might be, wherever. But sometimes we'll have to do that across Leeds, Calderdale, Kirklees, Wakefield, Bradford and Craven. And then sometimes I'll have to do it in West Yorkshire. But the idea of place is to make it simpler, because you know what Leeds means, what Wakefield means, whereas you probably don't know what all of the acronyms that we often fall into mean. So that's it in a nutshell, trying to bring the council pound and the NHS pound together to spend wisely on driving the biggest improvements and outcomes that we can.
Yeah, I respect you for that, Rob, but I have to disagree. It means nothing to nobody, but anyway, we are where we are. Yes, Bradford means something.
Yeah,
that's where I live.
And I think we won't use that. We'll use the language of Bradford and Calderdale, Kirklees. We won't use jargon. No,
that's fine. That's fine. Okay, thank you for that. I mean, we could talk about this forever. So many questions. It really is complicated. I don't know whether someone's intentionally trying to make it complicated or whether it's not. But you've helped shed a light on quite a lot of questions we have today, I think. So thank you for that. I think we'll be having a meeting later on just to discuss this ourselves, actually. So there might be a load more questions that are coming your way, but in the meantime, thank you and congratulations from me, Rob. Look forward to meeting you when you come to Bradford. And that's the end of the item. So thank you. Welcome to stay, obviously. Okay, so we'll move straight on to the next one then, which is Yorkshire Ambulance. And we've got Rod Barnes and Pat Keane, I think, to present the report.
People plan next, I think, Councillor.
Sorry?
Is it the people plan? Is it the people plan or the ambulance next?
Ambulance.
Ambulance.
All right. Okay. Sorry.
And then people plan. Yeah. Okay. So who's going to kick off?
Shall I kick off, Chair? Hello, I'm Rod Barnes. For those of you who don't know me, I'm Chief Executive of Yorkshire Ambulance Service. We've circulated a brief report, which I'm happy to talk through in a bit more detail. As the report says, the period of the pandemic, and certainly the position since April of this year, has placed unprecedented pressures on the ambulance service. There are 10 ambulance services across England, and all 10 services are at REAP 4, which is our highest level of escalation. We know that there are pressures across all parts of the health and care sector, and those pressures are adding to the pressures that we're seeing across our three main services, the 999 service, the NHS 111 service that we operate for Yorkshire and North Lincolnshire, and our patient transport services as well, which take patients to outpatient appointments and move patients in between hospital facilities and do on-day discharge activity. All of those services have seen unprecedented levels of demand. If I go through quickly just each service individually, for our 9 services, our contact centre has seen really sustained pressures. We've seen call volumes up about 25% on what we were experiencing pre-pandemic levels. That's placed a huge challenge on the service, and unfortunately that's had a really detrimental impact on our call response times. Prior to the pandemic, we would have probably seen received about 2,800, 2,900 calls a day. That's on average, that's now around 3,900. Now, an element of those calls are repeat calls because people have had delays getting a response to their calls, or delay with the ambulance attending the patient. But we know that 999 demand is up around 6-7% on what we were seeing pre-pandemic levels. Some of that activity is related to pressures in other parts of the system. So if patients are struggling to access services in other areas, struggling to access primary care, then that is resulting in additional calls coming through into 111 and 999. Particularly in our 111 service, we've seen an increased level of what we call in-day activity. But in response to the challenges that we faced, we've kicked off a huge recruitment and training effort across the organisation. We've got about 35 additional call-taking staff in our EOC in Wakefield, and we've got another 65 staff going through recruitment and training at the moment. So by the end of this financial year, we'll have over 100 additional staff within our control room. Coupled with that, we're also increasing the frontline staff that we've got to respond to incidents. And we're midway through, again, a big recruitment exercise in terms of qualified paramedics and our emergency care assistants who pair up with paramedics in ambulances. So that work is ongoing. I'm pleased to say that we're seeing good progress there, and that's started to feed through in terms of improved call response times and improved response times to patients, but we've still got some way to go, certainly in terms of ambulance responses before we're back where we'd want to be in terms of meeting the national response standards for ambulance responses. Some of you may have seen, both in terms of the national media and health media, the focus that there's been on ambulance handover delays outside of hospital. The Association of Ambulance Chief Execs published a report a couple of weeks ago highlighting the risk to patients for handover harms. I'm pleased to say that at the time that report was done, and the analysis for that report was done in January of 2021, Yorkshire was the best performing in terms of handover delays. Since then, though, unfortunately, we have seen sustained pressure across virtually all the hospital sites in the county, and West Yorkshire has historically been very good in terms of ambulance turnaround, although we have seen some challenges in recent months at hospital sites across West Yorkshire. In terms of our integrated urgent care service, our 111 service, year-to-date demand is up at call demand is about 16% higher than we were seeing this time last year. Again, that's a reflection of the challenges that we're seeing across health and social care. We have had particular challenges in our contact centres in terms of sickness levels of staff. As you'll be aware, Yorkshire and the north of England has been particularly challenged in terms of the pandemic. Right through from spring 2020, we've seen fairly challenging conditions in terms of levels of infection, which have fed through to call volumes and activity across our service lines. We're undertaking a lot of work in terms of staff health and wellbeing initiatives. I'm pleased to say that some of the work that we've been doing within our contact centres has been singled out by the charity Mind and the Royal Foundation as an example of good practice, where we've put additional support in for mental health wellbeing. We're increasing the support that we're giving in terms of specialist wellbeing support, rest and relaxation facilities on site so that people can take a break. But unfortunately, the nature of the demand that we're seeing and the pressures on the service are placing additional pressures in our 111 and our 999 contact centres. Sickness has started to come down slightly. I think recruitment is going to be critical, and getting the new staff in to take some of the pressures off of those staff. The staff that we see working in our contact centre, not particularly highly paid, often people coming in from a fairly young age, and as you can imagine, the types of incidents that they respond to on calls can be particularly stressful and particularly challenging for those individuals. So it's why our focus is very much on supporting the health and well-being of those individuals. As somebody said earlier, people are the most important thing that we need to do to support them at this moment in time. Even moving across into our patient transport service, although there was a reduction in the level of routine outpatient activity, that started to increase steadily back up to normal levels. And we also saw a large increase in inter-facility transfers. So that's where patients moving in between hospital sites, and on-day discharge activity as hospitals were looking to maximise their capacity. So our on-day discharge activities increased by something like about 20%. One of the particular challenges that we've had for patient transport services is social distancing. That's seen us move from conveying 2, 3, 4 patients per vehicle to quite often just a single patient on a journey. So in terms of actual vehicle journeys, those have increased by about 30% over the course of the pandemic. So that's required a huge logistical exercise, both for the YAS patient transport ambulances, but also our partner arrangements with independent sector providers and community transport organisations to increase the capacity that we've got there. In terms of ongoing work, that, as I said before, we've got strong recruitment going on over the winter period, recruitment and training, both in terms of frontline ambulance crews. We should see about 350 additional staff in place as we get into March, and close to 30 additional ambulances on the road. Within our contact centre, 999 contact centre, we should have about 100 additional call answering staff in place over that period as well. We've also got plans to recruit into our 111 service and help relieve pressure there. I think we are experiencing some pressures in terms of recruiting additional staff into 111. People will be familiar with the recruitment challenges that are being seen across the economy at the moment, and I think our recruitment into 111 is a reflection of that. But similarly, we're looking to recruit several hundred additional staff into 111 over that period. That's just a high-level overview. I'm happy to take any specific questions that people have got, or expand on any of those particular areas.
Thank you for that. We've got Councillor Hutchinson first.
Yeah, thanks a lot for that report, Rod. I can't imagine how frustrating it must be to be running a service where so many of your crews are having to stay in hospital car parks because the hospitals are rammed full, rather than being out on the road treating people. But we know that the peak demand period for the NHS is typically in January and February. And I was wondering what is left in the tank to actually be able to deal with that anticipated peak demand, whether there's been any sign of progress in reducing the handover times at the hospitals throughout our region. I also wondered that we get media reports that more people are attending accident and emergency because they can't get services from primary care. If that were the case, I would expect there to be more cases where crews are called out to homes and then then end up finding that they can deal with those problems at home. And I'm sure there's an even greater incentive for crews to do what they can at home rather than bringing people into hospitals and being stuck there for hours and hours. But I was wondering whether those concerns had been reflected in the figures of the numbers of people who call crews out and then don't need to go to hospital.
Thank you, Councillor Hutchinson. I do want to emphasise the point that we fully appreciate that other sectors, other parts of health and social care, are experiencing exactly the same challenges that we're experiencing in terms of staff sickness, social distancing, and higher levels of demand generally. In relation to the challenge of hospital handovers, I can't say that we've seen a reduction so far. Certainly since January, the level of delays that we've seen in terms of hospital handovers, around January time, we were losing about 2,300 hours a week, which is about 230 ambulance shifts, generally speaking. That level is around about 1,000 hours a week higher than that now, so about 330. That said, we've had really constructive meetings with partners and clinical leads across the acute sector. I think we all recognise that we need to do everything that we possibly can to minimise the risk of harm to patients, and we're in advanced discussions in terms of what additional things can potentially be done to help reduce ambulance delays. The types of things that we're talking about are ambulance divert policies, potentially cohorting patients at the emergency department, whereby paramedics would potentially be looking after more than one patient, and also rapid triage by ED clinical staff when the ambulance arrives to try and take the patient into the ED department, releasing the crew as quickly as possible. Those are some of the more immediate things that we're looking at ahead of the big winter challenge, as you say. We would normally expect that to be getting into tail end of November, right through to January, February time. Prior to that, we've been working with partners within West Yorkshire ICS to maximise use of alternative pathways for patients on things like mental health, same-day emergency care services, and a number of clinical pathways. So overall, over the last couple of years, the proportion of patients that we're conveying to an ED department, emergency department, is reducing. On average, I would say it's about 55% of the patients that we respond to through our 999 service end up being conveyed to an emergency department. In terms of the additional demands on our services and the types of patient coming through, I mean, Rob was mentioning earlier the importance of social care as part of that, and I think all healthcare providers would recognise the importance of having really strong, sustainable social care services. There was an interesting report published by the British Red Cross last week, which did some case studies and analysis of patients self-presenting and conveying to hospital emergency departments. And I think that reflects that we possibly are seeing slightly more patients than we would normally expect to, given the capacity constraints that we're seeing in other parts of the NHS and other parts of social care.
Thank you very much. But you feel that there is something in the tank still?
Yes, there are certainly measures that were lined up to take, as well as the recruitment and training that I've already described, in terms of different protocols outside emergency departments, and again, maximising the use of alternative pathways where we can.
Good luck to you.
Thank you.
Thank you for that, Roger. We've been looking at that report actually by the Red Cross, and it's saying that figures suggest that less than 1% of the population account for 16% of emergency department visits in England. I mean, that's terrible. One lady who a marriage had broken up, she'd not got over being abused as a child and so on and so on. So she used to take an overdose every week because she wanted to go to hospital because that's where she felt safe. Now, clearly that's a mental health issue rather than an A&E issue. But I was just wondering if, like as local authorities, could we help look at that, tackle that, or have you been working closely with local mental health support organisations and so on and so forth? Because that's something that really needs looking at, doesn't it?
Thank you, Chair. We do. We've got a team that we call frequent callers team, who work in both our 999 control room and our 111 control room, and they work on a case management type approach. So where we get people who are phoning us a number of times, we work in partnership with mental health services and other agencies to try and get the best response to those patients. And I'm pleased to say that's been really effective up to now.
That's good. Good to hear. Pat, do you want to come in from your
Thanks, Chair. It was on that point that there's been obviously quite a wide range of investment into mental health services, and there's been a particular focus on within ambulance services. So particularly how we can increase the number of clinical advisors with a mental health expertise at the point when people phone for advice, so we can signpost. We're also looking at greater support into ED, but the big focus is upon prevention and trying to support people and case manage. So we're recognising, and I think it's part of that wider discussion based on the previous question about recognising we need to wrap the integrated urgent care system around your ambulance services and work closely with them. So Rod's mentioned some of the issues around same-day emergency care support, so people can access services, don't need to go to ED. There's a much stronger relationship with primary care and hospitals around that route, looking at alternative pathways, the excellent training and development for paramedics in hear and treat, see and treat. So in other words, that conveyance that Rod mentioned, we're seeing year on year the reduction in people who are actually needing to be conveyed to ED because the paramedics have got other tools in the box and can take. Unfortunately, I mean, those have all been moving in the right direction, but we've just seen such an impact in the demand that's overtaken a little bit. But I think the question about have we still got some tools in the box, I think we have, and we have been, as part of winter planning, we've been working with ambulance services on a whole system basis. So looking at what we need to do to support ambulances in their core role, but also looking at what we need to do as a wider system to support people who need urgent services and offer them a wider range of services. So just to pick up on that point, Chair.
Yeah, no, that's really interesting. Thank you. Of course, we've got the workforce issue again, but I guess that'll come up in the next item. Rob, did you want to say something on that?
Just very quickly, Chair, just to give a shout out to the work that we're doing across West Yorkshire on people with multiple issues. So people who are homeless, have drug and alcohol problems, may have mental health issues and so on. And that population requires a sort of group of targeted interventions. So we have a programme of work on that specifically, which is helping to reduce the amount of sporadic contacts that people have with emergency services. It's really good and powerful work.
Excellent. Yeah. Councillor Smage?
Yeah, thanks. I was wanting to ask about managing the demand, because when you've got so much demand, and as you mentioned, some things fall by the wayside because you're just trying to manage the demand. And there's a lot of concern about response times, etc. And if you haven't got the vehicles that are out and about and the crews to respond to those calls, your response times lengthen, don't you? So I wonder what work you were doing to look at what extra things you need to put in, because at one time you had different teams, didn't you? Presumably, from what you've been saying, you have that at the moment, different teams for different types of calls to try and avoid ambulances having to go to hospitals and with people hospital avoidance. And so I'm wondering what work is happening to look at what extras you need to put in place to try and reduce those pressures so that people have somewhere that they can go for help as quickly as possible, and not necessarily for those that need to go to hospital. Thank you.
Thank you, Councillor. As you say, there are a number of different services that we have, as well as the core emergency crews. We have lower acuity crews that we would potentially send to respond, and volunteer crews, volunteers that we can potentially send to respond as well, where there's low risk of harm to a falls patient or a situation like that. But also we do signpost patients to other services, including voluntary sector services. Around and about 10% of the calls that come in through the 999 service are actually answered and responded to just by the phone, in terms of signposting them to a different part of health and social care or the voluntary sector, or by giving them some clinical advice over the phone. There are other things that we are looking at. We're continuing to expand the number of links that we've got to different pathways of care, things like being able to book people directly into urgent treatment centre clinics, GP clinics, but also in terms of response, one of the things that we're looking to expand at the moment is being able to refer patients into the 2-hour urgent community response teams. So that those are part of the community sector rather than the ambulance service. So there's an awful lot of work going on to increase those alternative pathways of care and try to connect people to the services that are most relevant in their local areas. As you can imagine, for a regional service like us, it can be quite difficult to get that detailed knowledge of exactly what services are in place, but that's something that we're very much focused on, working both with ourselves, but also through partnership arrangements, things like rotating paramedics into primary care settings to get a better understanding of delivery of community services in local areas. But also we have something called Directory of Services, and expanding the Directory of Services to take on more and more community pathways and third sector organisations as well, that we can refer patients into for things like alcohol advice, mental health advice.
Okay, thanks. So my next question then is, so what involvement going forward will you have in the new arrangements for the ICS and the different places, etc.? Because quite clearly the ambulance service is part of that whole system and needs that information from the whole system to be able to work. So how are the ICB partnerships, etc., connecting with yourselves to be able to give you information on places? Thank you.
Thank you, Councillor. We're very stitched into the ICS arrangements that are in place in West Yorkshire and in South Yorkshire and Humber Coast and Vale. I attend the executive meetings that were described earlier. We've got an integrated commissioning forum that Pat Keane and I both lead on. So that brings together representatives from the three ICSs across Yorkshire, and informed by discussions at place. We've got the urgent and emergency care work that goes on across West Yorkshire, which as an ambulance service we're heavily stitched into. What we are looking to do at the moment is strengthen our specialist and advanced paramedic arrangements so that they're better connected into place-based arrangements, and the paramedic rotation that I described earlier is an element of that. But as we increase numbers of advanced paramedics, we are hoping to stitch those far better into the conversations that are going on around development of local services, development of local pathways within primary care networks and other local healthcare decision-making bodies.
I think we've got Pat and James want to come in.
Just on that, thanks, Chair, just on that last point. Yeah, so we brought together a working arrangement across Humber Coast and Vale, West Yorkshire and South Yorkshire and Bassetlaw, because that's a range of that's the geography that's covered by Yorkshire Ambulance Services, for a number of people, so that we can have a single conversations at scale about the things that we can do once and make sense to do once, but also then where we can do things which are more nuanced to an individual place or district. And I think that's a really important element of that going forward. So there's some huge opportunities around technology that we can do once across big areas, but some of the pathway development work that Rod's referred to is much more localized. So it's getting that balance between being able to do things once right across Yorkshire and Humber, but being able to do more bespoke things. And that's where we're developing the relationship. And we've been working alongside all three ICSs as they move to ICBs to understand how ambulance services are both commissioned in the new world, but also how we can stitch in Yorkshire Ambulance Service into those conversations around providing services, and particularly about urgent care services. So very much part of that development ongoing wise, both from a commissioning and from our clinical pathway development perspective. Thanks, Chair.
James,
do you want me to come in? Yeah, sorry. So just building on what Rod said. So sorry, I didn't introduce myself earlier on. I'm James Thomas, I'm GP. I'm the clinical chair for the clinical forum at West Yorkshire. I know I've been here before, but just make sure I introduce myself. But just building on what Rod said, and in terms of your specific question, Councillor Smage, in terms of that linking in with the ICB and the arrangements there, the other addition is that clinical leadership and ensuring that there's that engagement with the clinicians into the system leadership arrangements there, and that's specifically through the clinical leadership and the clinical forum. So we have links with YAS into the clinical forum across our ICS, which is where our senior clinical leaders come together there, and that brings in the views from obviously from YAS, but also interlinks with place-based arrangements in Bradford, Leeds, and so forth there, as well as their local arrangements there. So in addition to what Rod has highlighted and the clinical arrangements that they have within YAS, it's also linking in that way to ensure that it's linking with the system that way. And there have been some strong links and better understanding, so that what you've heard in terms of those partnership arrangements, partnership ways of working that Rod has clearly highlighted across, we're getting that kind of clinical leadership built into that as well.
Okay. And Councillor Ramsey.
Thank you, Chair. I think I wanted to come back to the lost hours due to handover delays and the work that you're doing around that. When you talked about 30 ambulances coming into the system over the winter, that sounds quite a lot. But when you actually were clear about the number of hours a week that you're losing, how does that trade with that loss?
So in terms of what I was describing, around losing about 300 shifts per week, the ambulances that we're bringing in would not quite equate to that, probably be about 50% of that figure. But as I say, you know, that isn't a figure that's come back overnight. We've been operating with delays of close to that order of magnitude for a number of winters now. But I am confident that the conversations that we're having with clinical leads across health and social care, particularly the acute organisations at the moment, will bring about some improvement as we go into the winter period.
Okay, thank you.
Okay, thank you for that. I don't seem to have anybody's hands up. So all I can say is keep up the good work. I don't envy you. You're doing a really good job under the circumstances. So that'd be a nice place to be in right now.
Chair, Kate, I think you've missed it. Just one quick question, if I may.
Oh, sorry, Betty. No, I didn't.
No, that's okay, Chair. It's been a full agenda today. And it's to Rod, obviously, echoing what fantastic work all the staff did during very, very difficult times. And they've got to be commended. But moving on in terms of the questions that have been asked are very valuable. But what I want to just ask a quick question on, please, Rod, is you mentioned slightly the issue of clinics and the system of people now being able to return to clinics. We've actually had an item on our agenda in the Wakefield Scrutiny last month that the waiting times for ambulances to transport patients who have a lot of issues in terms of their health and in wheelchairs, they're classified as 1T or 2T. That means that somebody with 2T needs 2 people to help them. That hasn't been happening on occasions. Apparently the system as it stands at the moment is it dependent who makes the referral, is that the patient themselves have to actually phone in to arrange for transport to clinics. And this has taken hours upon hours upon hours to get an answer to it. And at the other end, having received the attention at the clinic, can be anything up to 7 hours waiting to return home. I'm wondering, you've mentioned you're getting new staff and you're getting some new ambulances in, and you're getting new people in your call centre, which they badly, badly need. Is there any way at the moment that the transport arrangements for these clinics can be reviewed? You can realise that the older generation, you know, hanging around this long and indeed being asked to arrange their own appointment, it can be daunting for some, and for some others it can be as natural as making a phone call to a family. So as the system itself at the moment is confusing to some people, is there any review that can take place in terms of the clinic arrangements for transport of patients?
Very timely question, Councillor Rhodes. I mean, first of all, I just want to come back to a figure I quoted earlier. In terms of the number of non-emergency patient transport vehicle journeys that we're doing, that is currently 30% higher than prior to the pandemic, and that's required a huge effort on behalf of the service just to increase journey numbers by that percentage, so that you can imagine that whilst nobody wants patients to wait for any period longer than a bare minimum, the service has come under a lot of pressure. There was a national review of a non-emergency patient transport services that was published a few months ago, I think going back into the summer. And that is looking at how we can improve services, provide better responses to those patients who are attending hospital clinics on a regular basis, such as renal dialysis patients, and how we can better work in partnership, again, across NHS patient transport services, community transport providers, and social transport providers, to make best use of the capacity that we've got and make sure that patients get the most appropriate vehicle for their needs. Now, an element of that is the booking arrangements, and trying to make the booking arrangements as easy as we possibly can for people. We in West Yorkshire are a Pathfinder site for that, so we are looking to mobilise some work at the moment in relation to implementation of those recommendations ahead of other parts of the country. We have recruited additional staff, or are in the process of recruiting additional staff into our non-emergency patient transport contact centre to improve call response times there. But I will take on board your comments and make sure that we're doing everything that we possibly can do to improve the service that we're offering patients.
Thank you for that, Rod. And I think at some point in the future, you may be getting a call to come to our committee to impart the good information, as well as the information you're dealing about clinics, etc. Thank you, Chair, for taking that question.
Okay, thank you. I think that's the end of that item. So thanks again anyway for coming. That was really helpful. And I think same as Councillor Rhodes, you're going to be invited to Bradford as well. In fact, I think Caroline's been trying to get in touch with you actually, but okay then, thank you very much, and we'll see you next time.
Thank you. Goodbye.
Bye.
Bye. Then I think, because we're way behind now, I've failed. So the next item is the West Yorkshire Plan, and we've got Sarah Brewer. Is Sarah here?
She is here, yeah, Councillor Greenwood. I'm not sure whether she's stuck on mute or something. Let me. You there, Sarah? Should I tell you what, let me just try and call her on Teams.
Okay.
I think Kirsty's with Sarah as well, Councillor Greenwood.
Oh, really? Probably seen the agenda and thought they'd missed it because they should have been on at 11:20.
Chair, could I just raise a point, please?
Yes, of course, yeah.
I was expecting this to finish about 12:10. I've got another meeting to go to, and you know, I cannot see this being, you know, the next item is scheduled for another half an hour.
Yeah.
So it's likely to be another hour before this is completed with the agenda as it stands at the moment.
Yeah, I think the Nightingale Hospital actually is going to be shorter than.
Yeah, but it's.
But this next one, yeah, you're right. Yeah.
Yeah.
We won't be done by 12:10 if that's when you need to get off. Sorry.
Yeah.
Well, we were talking about having a meeting again, weren't we? Sort of after this, but I don't think any of us are going to be able to make it now because I've also got a meeting after this. So shall we do it by email? And anybody who's interested in having an informal meeting about the ICB stuff, shall we do that? Okay. Sorry, Councillor Baines.
Yep.
These members, they ask too many questions. Ian.
Yeah, so Sarah Brewer can't get her camera on or her microphone off mute, so she's going to dial out and dial back in again. Sorry, I missed the conversation there. Are you still wanting to do this item now quickly? Is that the plan?
Yeah, no, it's just Councillor Baines has got to get off for 10 past 12,
okay.
but we're not going to be finished by then. So
okay, so Sarah's dialing out and dialing back in again.
Okay.
Fazana, I don't know if there's a dial-in number you've got as well as the link. So if you can't, this might be her.
I think Kirsty's just come in.
Kirsty's just come in.
Hello.
Oh, and Sarah's there.
Sarah's here. Yeah.
Right stuff.
Chair.
Yes.
Is it worth moving on to the Nightingale item while the people plan is sorting itself out?
Perhaps actually, yeah.
They're here now. They're here now, Councillor Greenwood. If you want, Sarah, are you there? Looks like the same thing's happened again. Apologies.
Oh, it's okay. Yeah. Well, the Nightingale one's only going to be 10 or 15 minutes anyway, so we can get that one out of the way if she wants to. Shall we do that? So if we move on to the Nightingale one now and just postpone that until they can both sign on. So, Mike.
Thank you, Chair, and I'll be very brief. The report that we've put together is a report of the work of the Nightingale Hospital subgroup that 4 or 5 members were involved in. We had a very useful and informative session with Steve Russell from Harrogate District Hospitals and 3 or 4 of his colleagues, where I'd like to put on record my thanks to them because they gave us full and very helpful answers. I put together this report following those discussions, and in the discussions of that working group and the previous discussion before this meeting, the view of members of that working group, and I think the broader members, was that we should that you should pass this report to the Secretary of State for Health and Social Care and to the Chief Executive of NHS England, and ask them to include this in the detailed review that will be taken of the response to the pandemic in 2022, and to request that they call this committee to give evidence to that review about the response to the Nightingale hospital aspect of the response to the pandemic. So I don't think I need to add anything to this, Chair.
Okay, that's fine. I think Councillor Clark just wanted to say something on it.
Yes, can I thank the committee for having looked at this. It was something I brought to the committee some time ago, and I think the two clear messages, and I would just like to say the same as Mike, that we had a very useful meeting with Steve Russell, and he was very open and gave us lots of information, because we hadn't seen any figures before, and there were all sorts of things going around. But I think the two messages that came out was that we were very fortunate to have tremendous frontline staff in our various acute hospitals across West Yorkshire, which meant that we didn't need to use the Nightingale. There are still some questions to be asked about whether they could have staffed it properly. We had a full discussion on that, but there are still very many questions to be asked. So I think the second point from the message from the work we did is that we really do need a proper public inquiry as soon as it is possible, because there are so many questions to be asked on the whole pandemic. But I think in relation to the Nightingales, but there are a number of other issues that were raised. But we were very well served by the frontline staff in West Yorkshire, or indeed the whole of Yorkshire. And I think one of the problems we now have with the present arrangements that are going on with the reorganisation within the health service is that Steve Russell and Harrogate Hospital are no longer in the West Yorkshire orbit. They're in Humber, Coast and Vale, but that's another matter. But I think we should be able to give evidence to the public inquiry when it starts. But once again, thanks for the committee looking at this. It was a very useful exercise, and I think it's the only exercise that's been done on a Nightingale throughout the country. Thank you.
Yeah, thanks for bringing it to Councillor Clark. I think we've got Councillor Hutchinson, Councillor Smage.
Thanks, Chair. I completely agree with Councillor Clark's observations. Can I suggest that we follow the possible courses of action as outlined in the report, in particular asking for a review of the national review of intensive care capacity, including staffing in the country's hospitals, and to have an urgent review of oxygen capacity in West Yorkshire's acute hospitals, which was found to be on a knife edge and was given as one of the main reasons for developing the Nightingale Hospital in both in Harrogate and elsewhere.
Yeah, I just want, actually, Councillor Hutchinson's made the points that I was wanting to make, so that's absolutely fine. I echo Councillor Clark's comments, but I also want to make the points about the intensive care and the oxygen, so thank you.
Okay, lovely. So we're going to, as it says in the report, forward it on to the Secretary of State, Health and Social Care, and to the Chief Executive of NHS England.
Move that, Chair.
Yeah. Everybody okay with that?
Agreed.
Thank you. Thank you very much for that.
You're muted.
I'm muted. Do we have Sarah? I don't think we've got Sarah on yet, have we?
Hi, I'm here. Yeah. Apologies.
You're here. There you are.
I am. Yes, I'm not unmuting and I'm not turning my video off.
Right, fine.
I do apologise for that few technical hitches.
Right.
And I'm joined by my colleague Kirsty Lowry Richardson from HE, and her Zoom has been crashing in and out. So let's hope we can get through the item, and appreciate we're way over time, so we will kind of keep it brief. So the paper that went out with the meeting papers was quite lengthy, so I'm not intending to go through it in any great detail, and really sets out kind of the context of where we are in developing the West Yorkshire People Plan, how we've worked with partners to develop the priorities, and gives a sense of the key priorities going forward. Just to kind of take a step back, the Health and Care Partnership in its 5-year plan set a commitment to develop a system-wide people plan by January 2020. But with the ongoing response to COVID, that has impacted on our ability to deliver to that time frame. However, it has provided an opportunity to really look at how we've had to adapt and learn and respond to COVID, and inform our people priorities going forward. We recognise that the workforce continues to face challenges and pressures, and I think the conversations that we've just had kind of touch on some of that. So the people plan, which is a strategy for our people, it isn't a detailed workforce plan, needs to set out how we will address kind of the current challenges, but set out the strategic ambitions for the future. I think it's really important to be explicit about it is a system plan, so it is aimed at our one workforce, so taking in health, social care, the voluntary sector, and recognising the key role of our unpaid carers. So the priorities within the plan have been informed through ongoing dialogue and engagement with our system partners and representatives of the workforce. But I think we recognise that we're not starting from scratch with this, and whilst we've been responding to the pandemic, work has progressed in terms of developing our people priorities. So the paper sets out the 5 pillars that the people plan will be framed against. So the system leadership to develop the partnership, there's looking after our people, there's belonging in the health and care partnership, new ways of working and delivering care, and grow for the future. So the plan will set out the ambitions against each of these 5 areas. It sets out what we're already doing to deliver on those, but we'll set out kind of what our future plans will also include. And the paper does draw out a number of examples against all of those 5 pillars. But just to draw on a couple for today. So in terms of system leadership, we conducted the independent review into the disproportionate impact of COVID on members of our community and workforce from ethnic minority backgrounds. So the key priority to make sure that we implement the recommendations of the review. In terms of belonging, we launched our successful fellowship programme, which is supporting 2 cohorts of colleagues in terms of developing their potential to take up leadership positions within our health and care system. In terms of looking after our people, we've launched the Mental Health and Resilience Hub, and have rolled out a number of occupational health pilots, particularly looking at supporting staff with long COVID, around menopause, around MSK, and really looking at how we can make sure that these system offers are available to our own workforce, including social care and the voluntary sector. In terms of new ways of working, we've launched our first phase of the rotational paramedics between the ambulance service and primary care, which I think speaks to some of the issues Rod spoke about in the last item. I think, in terms of maximising the existing workforce, it really is looking about how we use the workforce in the most effective way. So looking at opportunities to look at workforce redesign, and we've been successful in getting funding to, as part of the CLEAR project, to work with mental health and UEC on looking at different models of workforce. And in terms of growth for the future, I think there's a few things to draw out here. So I think recognising the importance and the opportunity that new roles can give us. So we've been implementing trainee nurse associates and advanced clinical practitioners. We're working with the social care sector and Skills for Care for looking at how we can really support in the here and now, but in the future around recruiting into the health and care system, into social care, and really making that attractive roles, not just around pay, but in terms of career progression and being valued. We're really keen to ensure that as a growth sector, the health and care system can really support social and economic development within our communities. So really looking at how we can support employment and attracting new people into the health and care system, and ensuring we've got a diversity of the workforce which is reflective of our communities. And just to touch on something Rob mentioned in a previous item around really ensuring that we've got a very effective approach to workforce planning and strategic workforce planning, which is informed through population health management, but the changes in care due to new ways of working, new models of care, but what does the digital and innovation agenda look like in terms of workforce? And part of that is working with the universities in Yorkshire to develop the Workforce Observatory, which will bring together all that wealth of data and intelligence and evidence to support more effective workforce planning. So those are just a few examples of things that we're doing here and now. The paper does describe more examples and gives indications of things that we will focus on in the future. I think it's really important to kind of stress that it is a workforce strategy, so needs to set the strategic ambitions, but really needs to be agile and dynamic as well to ensure that we can respond to changing needs and priorities. And it's very much about the actions that underpin the ambitions that will make the difference to our workforce. So I'll just pause there, Chair, and open up for questions.
Thank you, Sarah. We've got Councillor Hutchinson first.
Thank you, Chair. In April 2018, Health Education England, the regional branch, published A Healthy Place to Live, a Great Place to Work, a Workforce Strategy, which flagged up the scale of the problems that faced developing a strategy. It had a lot of figures of where the gaps lay, which particular disciplines gaps lay in. I fail to see that the report today shows any sign of progress against the strategy that was set out in 2018. In fact, it seems to have gone backwards to looking at principles rather than actually biting the bullet and getting on with training up the people that we need to provide the services that we require. I mean, it's completely devoid of any sense of the scale of the gaps that there are in the current workforce, whereas we've seen reports that Leeds Teaching Hospital NHS Trust has nearly 700 vacancies for nurses, midwives and ODPs, a 13% vacancy rate, and this has profound implications because 287 operations were postponed in July and August because of staff shortages in critical care. Radiology, nationally, there's a 33% shortfall in the number of radiologists, which is predicted to rise to 44% by 2025. And there is a particularly dire need for interventional radiologists, which has been instrumental in the reconfiguration of services being withdrawn from our local hospitals to be centralised because of those staff shortages. We're looking at reconfiguration of clinical oncology, clinical non-surgical cancer treatments because of lack of clinical oncologists. The NHS has just 5 more clinical oncologists than in 2018, but a need for 200 more. And UK trainees currently will only be sufficient to meet half the needs. And we know that general practice is struggling to meet its capacity requirements. And Calderdale, the borough that I represent, has the lowest number of GPs per head of population of anywhere in Yorkshire, unless you include Hull within Yorkshire. So we know that there are huge gaps. These are not being articulated in this report. I really wish that we could see a proper strategy that will bridge those gaps. I'm sorry if that sounds negative, but you know, this is incredibly frustrating when we see services falling over because of lack of staff and no apparent sense of urgency to actually deal with it.
Okay, so I was going to come back in on that.
Shall I come back in on that? So I think it's important to recognise that the scope of the people plan is it is a strategy. It isn't a detailed workforce plan. So it isn't going into detail of how many consultants we need in this principle or that principle, or that workforce plan as part of the ICB. In the future, we will have a duty to do a 5-year system workforce plan, which will get into that territory. So the scope of this is really around kind of the strategic direction for the workforce across the whole health and care system. That being said, the shortages or the challenges that Councillor Hutchinson has described, the work is underway to look at how we can look at recruitment and retention of those. We know there are challenges in those areas, and just because it's not articulated in the plan doesn't mean to say that work isn't happening. So I think it's just understanding the scope of the people plan in that respect.
So when will we be able to see the plan, not the strategy?
So we will have a duty from the 1st of April to develop a 5-year workforce plan for the health and care system. The building blocks that we need to kind of inform then around the strategic workforce planning, which I've described, all need to feed into that. The commitment was to develop, the people plan for the health and care system, which this is what this is intended to do.
Rob, do you have something you want to say?
Yeah, just wanted to firstly to say that it's critical that we have the plan. We've currently got a set of arrangements which helpfully, as we look at our activity, our financial, our workforce planning together, brings those and says, okay, so over the next, at the moment we're in a very strange position, aren't we, where we're planning for the second half of the year. We're planning in half years in the NHS at the moment. So the second half of the year, we've submitted a group of plans that says, this is how much activity we're going to do, this is how much it's all going to cost, this is how many extra staff we're planning to employ. And in the first half of the year, we've had some successes in some disciplines. So much more, healthcare support workers, training nurse associates, those sorts of disciplines, compared to registered nurses, where it's much more difficult to grow the workforce. It's easy for us to retain the staff we've got, which is the biggest pool of talent that we have. So there is integrated workforce planning in the short term. So I think that's the first thing to say. I think the second is, I wouldn't want there to be a sense that there isn't a sense of urgency here. Because although we have these statutory duties coming our way, we've always said that we should be trying to develop workforce plans and implement them, because that's an essential part of what we do. Because I think, as Councillor Hutchinson said earlier, it's the people who deliver. So if you look at some of the work we've been doing around significantly increasing the placements for nurses in all of our providers at the request of Health Education England and local universities, we've really increased those to take as many people as we can into training. If you look at what we've done around some of those new roles and enhancing the number of people who can get onto the career ladder in terms of healthcare support work, then into apprenticeships, then into registered groups, those are all sorts of steps that we're taking now. I think, as Councillor Hutchinson says, what we really need, I think, is kind of, like a step diagram that says, this is how many staff we've got now, this is how many we need in 5 years' time. We're going to have more because we're recruiting some from overseas, which is what we're actively doing at the moment. We've got some really positive international recruitment work we're doing, because we're retaining the staff that we've got more for longer by being flexible, and that we've got more people coming out of university who want to stay here, as well as recruiting people from communities who currently find it difficult to get roles. You know, there are 350 different roles in the health and care sector, and we need to try to fill as many of them as possible and address the kind of shortages that Councillor Hutchinson has described in things like imaging, registered nursing, learning disability nursing, and elsewhere. So please don't think that this strategy suggests that there isn't a sense of urgency or active work going on at the moment. But it's good to hear, you know, what you would prefer to see and how we get that in front of you.
Yeah, thanks for that. That was interesting, Rob. Sorry if I've missed it, but do we know what the shortage is? Have you got a number for West Yorkshire? How many are we short of?
In terms of which
overall
discipline
NHS? Yeah.
Well, at the moment, we know that, for example, you know, registered mental health nurses, we have a 10% vacancy rate. Something around that it fluctuates around that. So we need to therefore create different kind of blended teams, and you'll see similar. And you know, it varies depending upon the discipline. You know, it's obviously easier to recruit healthcare support workers than registered nurses, for example.
Of course, I think, is it something like 100,000 across the country or something like that? I can't remember vacancies.
It will be there or more, I would say. You know, given if you think about the health and care system together, in West Yorkshire there are about 100,000 staff in health and care.
Chair, can I come in?
I've just got Councillor Smage, and then you, Betty. Betty, do you know how to put your virtual hand up? Because I keep missing you.
That's okay. I'll wait after Councillor Smage.
No, it's okay. Do you know how to put your virtual hand up?
I do. I'm having a bit of difficulty.
That's all right. I'll just have to keep watching you for when you put your hand up. So you can go in after Councillor Smage. Okay.
Okay. Stuck again.
There we go. Just a quick questions. I see from your mental health trusts have got putting in a collaborative staff bank, which is very good, but I don't see anything on how the problems across NHS trusts in the West Yorkshire are being dealt with. We already had pre-pandemic, we already had problems in the differences of ability to recruit in between non-teaching and teaching trusts. And we already have, as Councillor Hutchinson has said, we already have problems in some areas where services are having to change because there's not the staff in some areas. And so I don't see from this document anything that really helps to address that in any shape or form. And I don't see a lot neither about you talking about current workforce and workforce retention and then implementing some new roles. But I don't see a lot, you talk about apprenticeships, but I don't see a lot about how to training and resource into the right source of training in the right sort of areas for the staffing that you need, that you can do on a West Yorkshire basis. But the most important point, I think, that I don't see is the working across trusts to be able to deliver services effectively and safely in the places where people need the services.
So I'll come in on that, and I'll hand over to Kirsty to talk about the approach to training. I guess kind of from an overarching statement, I think a combination of everything that's in the paper will be part of the solution. So there isn't just one solution to what you've described there, Councillor Smage. I think there's something around, if we think about retention, it isn't just about kind of pay, it's about how we're looking after our people, how we're feeling, how we're making them feel valued, how we're supporting their training and development, in terms of looking at how across trusts we are supporting tackling some of the challenges. the new ways of working and really looking at new roles is really key to that. So it isn't just about increasing nursing numbers or those traditional roles, but actually really maximising the value that the new roles can bring as part of that wider workforce design. So some of the examples in the paper touch on that. So I think it is a combination of different strategies to achieve the overall solution. And Kirsty, can I just bring you in just to talk about the approach we're taking around development at a West Yorkshire footprint? And then I think Rob's got his hand up and will want to come back in on some of that.
Yeah, absolutely. Thank you, Councillor Smage. So basically, the approach that we're taking is to try and be as accessible and flexible as possible in terms of the training offer, so that we have maximum benefit for the maximum number of people. What we found is the apprenticeship route is very much advantageous in the sense that it's more accessible, allowing on-the-job training. So we're pursuing apprenticeships all the way from the entry level roles all the way up to the advanced clinical practitioner. So in West Yorkshire, we were actually the first area nationally to adopt the apprenticeship for the advanced clinical practitioner role across the board, and we've found that to be really beneficial, because what it allows is it allows the trainees who are coming from their mother professions, so whether they be an AHP or a nurse or a pharmacist, to train whilst on the job, so they're still delivering service at the grade that they already work at whilst becoming an advanced clinical practitioner, and then obviously moving into a slightly different role with an enhanced level of clinical skills to enable them to deliver service in a slightly different way. And in that same sense, then they can take some of the burden from the wider team, because the team can then work in a different way in the way that it delivers the clinical care. I'm not for a second suggesting that we replace doctors with anybody else, but if you put advanced clinical practitioners into a medical team, into a clinical team, then actually it reduces the number of doctors that you might need within that team, because the way that the clinical care is shared amongst the whole multidisciplinary team is different. So it allows maximum sort of benefit and efficiency for the patients, but also really importantly, it's giving these individuals an opportunity to upskill and to move on a career journey themselves, which plays into the retention part of the conversation as well. So apprenticeships have very much been important in that sense. We also undertake across West Yorkshire a learning needs analysis that we aggregate at place. And then we triangulate with programmes and with specialties and sectors to ensure that what we're doing with the HE funding envelope on an annual basis, that we're appropriately steering that funding to the courses where it's most needed to get the maximum benefit. So we undertake the learning needs analysis that then, and there are several sort of groups and committees that undertake the work streams. That all then comes together and it informs how the workforce development funding from HE into West Yorkshire is spent, both with our higher education institutes in doing sort of academic programmes at advanced levels and academically accredited modules, but also with local training providers, with the hospitals, the teaching hospitals, when they can actually deliver the training themselves. So we try to have a very multifaceted approach to give us maximum flexibility to enable sort of maximum benefit and maximum accessibility for all of our workforce to either upskill or to enter into the health and care workforce in the first place. I'm going to stop now and pass to Rob.
Yeah, just on, I think Councillor Smage makes a really good point about organisations working together, and I would say that the benefit of having these arrangements, whether that's in places or across West Yorkshire, is that people can be employed by one organisation but work in all the others. And we've tried to put those arrangements in place in our mental health providers and our acute providers. So the training is passportable. You don't need to redo your mandatory training. The checks that are done around your employment are passportable, so you can work in any organisation. And then good practice, like working carers passport. So I think we heard 1 in 3 of our staff care for somebody informally, because they feel a sense of duty or because they love them. And that's additional pressure on them as individuals and additional responsibility. So employers need to be flexible. So good practice around working carers passports have been rolled out right across West Yorkshire and all our employers. Then I think more fundamentally, when it comes to some of the specialties or professions where there are shortages, we've started to see hospitals coming together as a network. So in the past, it didn't really, you know, every hospital trust was an island, and they had to think about what staff that they wanted to deliver their services. What we're seeing increasingly is people say, if you look at vascular services, for example, the West Yorkshire model is now a network. So you all work for a group of organisations that are delivering across the network. So you've got to look at the capacity available for specialist vascular services in Bradford and Leeds, but vascular services right across West Yorkshire. So you start to look at that differently, you start to plan it differently, you start to see people working differently. So you stop robbing Peter to pay Paul, and you start looking at everything together. So behind all of the changes that we're seeing, what in the jargon is provider collaboratives, or in the jargon is places, you're starting to see these developments. So another final example would be, you know, growing apprentices into the health and care workforce under the current rules could prohibit third sector charities and organisations getting access to the apprenticeship levy. So we've sponsored those organisations to receive the apprenticeship levy so that people can do their apprenticeships in those organisations and do the work that's required. So we can only do that if we've got good places. We can only do that if we've got good provider collaboratives. So I think much of this is about maximising the opportunities inherent in those to get this work done differently and together. So I think, Councillor Smage, if that doesn't come through clear enough in this, I think we need to strengthen it, because that's been some of our most successful work, I think, to date.
Yeah, I think it doesn't come through at all. But also, I think the point is that I understand the workforce issues, but people need services in the right place and it safely. And the more there are workforce issues that cannot be addressed for whatever reasons, then the more we're going to see services contract into different, as you say, places or networks or whatever. And is that the way forward that you're going to be going? Or is it trying to put capacity in there to make sure that, yes, people are working in teams, but they're working in teams in different places across West Yorkshire?
And that's very much the idea that if you look at, you know, the old models are about winners and losers, I think. You know, so people under previous arrangements might have aspired to work in a specialist centre because they saw that's where the action was, that's where the interesting work was. In a networked model, you get to work there, but you also get to work across the piece, and you get to flex your capacity when there's pressures in different parts of the system. So that's exactly what we're trying to do, and I think it's something that plays out in multidisciplinary teams. You know, doctors, nurses, allied health professionals, carers, healthcare support workers, social workers, and everybody else, trying to get more into a rotational way of working. So you've got experience of what it's like going to, you know, visit a granny in Normanton. Where, you know, what's that like as an experience? What's it like to work in the specialist stroke unit in Leeds? You know, these things are part of what we're trying to achieve, and seeing the workforce as a collective resource. It's really important that we do that.
Thank you very much for that, Rob. We've got Councillor Swift and then Councillor Hutchinson.
You've forgotten me
again. I didn't see
I'm
any
so
reference.
sorry. I'm so sorry. Councillor Rhodes. Just keep shouting.
Now then, okay, that's fine. That's fine.
Sorry.
I'm sorry. Again, I don't want to sound negative, but I've been involved in that many reconfigurations, both with working in the health service and as a volunteer before I got there, that I can't count how many times I have heard the word strategy and vision and how long it's going to take. In my own authority, my view is you could paper the town hall 10 times over with strategies and visions. And when I look to the outcomes, I think, well, where are they? I echo Councillor Hutchinson's views on this. First of all, why is it being revisited again when about 3.5 years ago, at a meeting over in Bradford, I attended with representatives from other authorities. Councillor Smage, Liz was there. And at that meeting, it was agreed that a workforce development subcommittee would be set up to look at the planning for the future. That did meet. What happened to that? What happened to whatever they found that would be an input into the situation we're in now? I don't find anything at all that's given me confidence other than, and do excuse me, and this is not personal to anybody, only I am tired of caring for the health service the way I have done for 40 years of my life and my family as well. To hear the jargon that, as I'm glad Rob used the word, the jargon that's coming up again. There is nothing here that's going to tell us what is going to happen. And I don't want to know about a vision. And I echo the need for a plan. Retention is the worry at the moment. Recruitment into a retention is the worry at the moment. We have out there in our hospitals and across our patch such shortages. Midwifery, for instance, that's national. That wasn't mentioned at all. That's national. We have such shortages, and I have personal experience of this in relation to my husband, my late husband. The value of the people in our hospital has never, ever been something that a lot of us have taken for granted. So I personally don't need to be told about the value, but I will shout it from the rooftops. But the value in our hospitals at the moment, and echoed by myself, night and day, and by people who are coming to me as their representative, both on the health committee and personally, who've known me for over 30 odd years, 40 years. The wards in terms of elderly care are being catered for and covered for with student nurses. Their value is beyond belief. Their value is beyond belief of what they're doing over and above because of staff shortages. The chair mentioned the shortages nationally and locally. Nothing that's happened in the last 3.5, 4 years on promises of increasing staffing levels has happened, except strategies. And I'm not devaluing your work. What I am trying to do is hopefully engage in some value to be put to it, because that's what it's all about. I don't want to reinvent the wheel, but I want to know this. How the dickens did we ever manage when we had the same demand in certain parts of the NHS? You've mentioned apprentices. I think they're doing a great job. I would love to see where, as Rob has mentioned, where you actually put your arm out into the community, into schools, into colleges to recruit. I was at another place, and I'll name it, Combined Authority, where we were actually talking about apprenticeships and the value, real apprenticeships, and the levy that's been mentioned. And when we asked about the apprenticeships there, we were told from the officers dealing with it, they had tremendous difficulty getting into colleges to promote the initiative of apprenticeships, and they had to use an excuse to get in. Where does any of your planning show where you're going to reach out now? Not 5 years, now. We can't wait. We just cannot wait. We had a value team, and you know what they used to be called? They were called auxiliaries. We can go back to auxiliaries. They were the main bread and butter on the ward for our patients, for our relatives. And you know what? The wards were bigger. They were bigger. We had the dedicated staff. We had the nurses. We had staff nurses. We had sisters. And then, lo and behold, we had matrons brought back. What we had as well was, and I get really passionate about this, Sarah and Kirsty, and do forgive me. What we also had, and I'll talk about Wakefield, and I know everybody can do the same. We had within our hospitals, Pinderfields Hospital was known nationally for two things above and beyond. One was the nurse training school, and the other was the burns unit. They were known nationally for it. What's happening in reaching out in terms of the training schools locally so that people and their families don't have to consider, can they afford to travel in this multidisciplinary role from Wakefield to Bradford or from Bradford to Leeds? Where does the money come to support them? We've had a multidisciplinary function in terms of movement of staff, and it's movement between the hospitals that Liz and I know about, Dewsbury, Pontefract and Wakefield. And let's get down to the basics of knowledge of staff, because this does bother me. We have these staff over at Dewsbury who buy a parking ticket for a month. And if they're moved over to Pontefract, that ticket is no good. They can't use that ticket over there in Pontefract. We're in 1A to NHS. What is wrong with the basics of the system when we're talking about looking after people, the people that run the service for people? Don't give me strategies, don't give me visions. I've had it with them, to be honest with you. And it's not you and it's not Kirsty, but we cannot wait for these things to take 5 years while we can see what's going on in our NHS. And it's not just us. We represent the elected people who are using these services across West Yorkshire, across the patch. And this is how we get to know, not through a strategy, not through a vision. We get to know it because people are telling us what's happening. What's happening when a 100-year-old lady has said, you can go home tomorrow? 100 years old, go home tomorrow. She passed away 3 weeks later. Shock. I can't tell you. This is the reality of what's happening. But please, please, just take it from me. I know what it's all about in terms of the work that you're doing. I appreciate it tremendously. But the focus has got to change. And I don't know how we're going to change it. Believe me, I think the people that are deserving of the service and actually receiving it, they know what's happening, and we do as well. And I'm sorry if I've got on my high horse about it, but I cannot listen anymore, Chair, to more strategies and visions that could paint every town hall across West Yorkshire. Do forgive me, Kirsty and Sarah, but I feel so passionate about it. I've worked for this for 40 years. Some of you weren't even around then, but I'll keep going fighting for the people. And I don't want to hear jargon, as Rob says. I want to see what's going to happen in terms of now to then to then. We need the plan. Please send us the plan, Rob. I don't want to see a vision. I want to see a strategy. I want to see a workforce plan. I want to know, as the chair has said, what's the vacancy rate? What's the recruitment? Overseas staff? What are we recruiting there in terms of the pandemic and what's happening at the moment? Will that be able to go ahead? There's doubts about it, where your shortages are and where the people are actually going into hospital and coming out sooner than what they should in terms of bed capacity. Sorry, Rob, I've known you a while, but I've been around this and around the houses too much to sit here and listen to the same thing again. And do forgive me, everybody else, but I do feel passionate about it.
Nothing wrong with that, Betsy. Nothing wrong with that. We need more people like you. So, Rob, do you want to?
Yeah, so can I just come in briefly before I
Yes.
need to go to a board meeting in a second?
Of course.
So Betty, you and I have got exactly the same approach, Councillor Rhodes, in terms of the general view of life. So what we say in our partnership is we should stop admiring the problem, start doing something about it. And just picking up some of the points you made about the kind of hierarchy of needs, if you like, that people have. Over the last 18 months, what we've seen, I think, across all of our employers is a much stronger focus on supporting the daily needs of our staff. So real action to address real issues. So here at Field Head, when my staff couldn't get food because the supermarkets were empty, we fed them. You know, when people were wearing PPE every day, which they still are, we gave them hydration stations, water bottles to fill, and made sure they had a space to go to get a drink and sit down.
I know, Rob, I have fingers out in every hospital with the staff, and they've told me what they're going through, and the challenges are beyond belief. I will never, ever be able to thank them enough for what they've done. But I'll let you go on because, yes, I know.
So those sorts of things, giving people extra leave, saying thank you, giving them a Christmas bonus because that's at Christmas Day at the last minute, those sorts of things, give people a sense of belonging. And actually, we understand what it's like when you've done a 12-hour shift on a mental health unit and you can't get any food in the supermarket. And what that's led to, I think we've had much lower turnover. We've actually got about 200 more staff in this organisation than we had previously because people haven't left. And getting people in, you know, we have got an international recruitment programme. That international recruitment programme's happening. It works across the mental health providers. People come in, it's not the answer to our problems, but it's a short-term fix. We've done virtual recruitment fairs targeted at different people, and we've started to go into schools and colleges in the way that you've described. Say to people, look, there's 350 jobs here. You don't have to be a nurse, you don't have to be a doctor. You could be a graphic artist, you know, you could be doing the communications, you could be working with people, you could be a peer supporter. There's all sorts of different things that you can do with us, and we need you, and we will value you as a person. We need to keep doing that, you know, we need to keep doing those things which make people feel valued and held in what is a very, very difficult time, where our staff, as you say, have been through indescribable things.
Yeah.
You know, having to hold the hand of somebody who's dying, who can't speak because they're on a ventilator, who can't see their family, who family can't see them, is something none of us want to go through, and many of our staff have gone through, or being faced with some of the circumstances that they have and are still facing. So this is the biggest thing that we have to deal with, and we have to look after our current staff. We have to engage future generations to come in, and we have to do more. So we have been doing a lot, and there are some positive signs because of that, but there's still a huge amount more to do because the demand is significant, and it's a demand versus supply issue constantly. And the way that we have allowed some things to change over time has meant that there's been a fracture between health and care, between general practices and hospitals. All of that needs fixing. And I think that's why we're doing all of the work that we are. But I hear what you're saying, and I share your passion for doing stuff. We need to do things to make things better. I do think it needs to be within a strategic framework. And we have to do one of these, partly because it's the right thing to do, and partly because Health Education England and NHS England are going to give the responsibility to us to do it rather than it being done nationally. And personally, I think we're the right people to try and do that, because we understand our staff, and we, working with the universities, can get a much clearer view about what the need is for the future.
You are indeed, and through you, Chair, I think it's time that the campaign to recruit actually went out in the community. You've got community centres, you've got libraries, you've got across every patch where you can actually recruit to people who do not think that they can actually come to work in the NHS because we went crazy in terms of exams, diplomas, etc., etc., etc.
Yeah.
But as you say, everybody can provide a valued part, but there's never anything that goes out in the community where people live, encouraging them to actually apply. You can do, not you can't do, Rob. Please.
Yeah. I think that's
Thank you,
exactly right. So just the final thing I'll say before I go, apart from thank you to the committee as ever for their very insightful questions and challenge, is if you look at things like Red Kite View, which is the new children's mental health unit opening in Leeds, we have recruited local people. We've gone out of our way to say, look, this is in Armley, which is not the richest bit of Leeds, and we should be recruiting local staff, and we've been successful in doing that. So I think that's a model which we should be adopting in most places. And I think credit to the national system saying that one of the things that we have to do as partnerships is maximise the economic and social value of everything we do. And I think that is working with local people, attracting them into working for the health and care system, because we've got to end this situation where we can't get staff and there are places where people can't get jobs. There must be a solution there that we can.
I look forward to our system in Wakefield, and I'm sure everybody else will, of getting these grand notices and I'll spread them all over my community in Wakefield, which is just down the road from you.
Yeah. Brilliant, thank you. Apologies, Chair, I need to leave, but others.
No, that's fine. Thank you so much for coming, Rob. And hopefully we'll meet you again. I'm sure we will.
I'll see you next time.
Yes, thank you. Bye. Okay, right, we've got 3 hands up here, and then I think we better call this to an end. So we've got Councillor Swift, Councillor Hutchinson, Councillor Smage.
Right. Kevin Swift from Wakefield. On the basis of begin as you go on, the report doesn't mention trade unions anywhere.
I assume you're asking if we've consulted with trade unions. We have a very constructive partnership with the area partnership group, who have been on this journey with us, so presented on a number of occasions to them on the plan as it's been evolving, and meet with them regularly on other kind of workforce issues.
Okay.
Well, no, I mean, my original comment stands. The fact there was no reference to it in the report suggests that whatever meetings they had, that not much came out of it. Otherwise, one would have expected to have seen some reference. That's my comment, Chair.
So the report does talk about workforce representatives, and that it's within that description that the area partnership group is part of that. So they have been part of the engagement on this.
Okey-doke. Thank you then for that, Councillor Hutchinson.
Rob Webster made the very sort of obvious point or important point about the need to retain staff. But if we look at nursing in particular, poor understaffing is one of the major drives to people leaving the job. They feel they can't do the job that they need to do because there aren't enough staff to do it. And so you get it, and that then exacerbates the problem with, you know, it goes into a downward spiral. People can put up with it for a short time, but they need to know that the cavalry is coming. And that's why having a plan that will actually address it and make it better is so vital. And the stress that's being put on moving staff around to plug holes in services actually worsens that. It doesn't recognise the importance of working in close-knit teams in a familiar environment where you know where stuff is kept, you know who to call on if you're running into problems, you know the other services roundabout, you know the capabilities and limitations of your team members and what you can delegate to them and what you mustn't delegate to. Close team working is vital to patient safety, but it is also extremely important in terms of the cost effectiveness of the services that you're running. And so this idea that patient passporting will just allow us to plug the holes as they appear, or the worst holes, is a self-defeating policy. And I would also stress that we need to note what is going on in community nursing, in district nursing. There was a report in the Independent published today by Sean Linton showing that we're sleepwalking into an absolute crisis in community care. And if we're going to look after more people outside of hospital, particularly care of the dying in communities, we must have good, strong district nurse-led community nursing teams. And I've seen nothing in any of the strategies, including the 2018 one, to suggest that we are doing anything whatsoever to address that. So please can those gaps be plugged, and please can we stop suggesting that by patient passporting it'll solve a lot of the problems. it'll produce problems of its own. It's all right in some circumstances, but it is not a panacea.
Can I just come in, Sarah, before you respond to that? Mike and I were discussing inviting the RCN to a future meeting as well, so if that would be helpful.
Yeah, absolutely. On the community health services, so we recognise the importance of out-of-hospital care and the importance of community health services as well as primary care services. So we are, whilst it's not described in the paper, we are doing work in looking at not just in terms of registered nursing, but the whole kind of workforce around community health services and more integration with primary care. Looking at the opportunities of new roles, looking at the allied health professionals. So it is absolutely within our sights. And just to say, in terms of some of the nurse recruitment we're doing at the moment, we are taking a system response to looking at where those nurse recruits are deployed to, recognising the importance and the shortage within both social care in terms of registered nurses and also in terms of community health. So it isn't kind of the acute trusts get the lion's share of all the new nurse recruits coming through. So we are taking that system response on that. I will say in terms of digital staff passports, that was brought in a response to dealing with COVID, a very unprecedented situation where actually we needed to be able to deploy staff to other organisations to be able to deliver care across the whole system. That recognising that we will still need, and there's still a benefit of to be able to deploy, particularly if we're looking at working across systems, to be able to deploy a workforce in the right circumstances to other organisations. And the digital staff passports just allows us to do that much more effectively and reduces some of the bureaucracy around kind of more mechanical ways of moving staff.
Please, can you work with the Queen's Nursing Institute? If we're having larger teams within the community, they need to be well led, and the leadership is not there. And so, we do need district nurses, not just more healthcare assistants and other people. Somebody has to actually take control of these teams and have the experience and knowledge to be able to do that.
I think I might have been muted when I said this earlier, but Mike and I have been speaking and we were going to invite the RCN to a future meeting anyway.
Yeah, this is the Queen's Nursing Institute.
Right, okay.
For district nursing and community nursing.
Right, okay. Oh, you did, Amy. Right, okay, Councillor Smage, you've got
just really quick, because I'm conscious of time. I think I agree with Councillor Rhodes' comments and also that Councillor Hutchinson saying about passporting of patients. I think this goes back to, if we don't get the workforce right, then it's patients that are going to have to be moving. And it goes back to one of the first questions about reconfigurations. We've been around this circle so many times, and you can just see it coming along on the horizon now. You can see it, but we also appreciate that staff cannot work at a pace that they have been working at for long periods of time, and therefore there needs to be extra workforce coming into the system to help those staff, because you just can't work at the pace that people have been working at for prolonged lengths of time. I think that this is a very detailed conversation that Scrutiny needs to have. And I wonder if instead of putting an agenda item into a meeting with other agenda items, we ought to have a meeting just specifically, additional meeting just specifically on this plan, and have various people to the meeting in order to give it the scrutiny and the consideration that the importance of this really needs. Thank you.
Yeah, I think you're right there, Councillor Smage. We can arrange that, can't we? I think Councillor Hutchinson, you're still the chair of our workforce group anyway, aren't you? So we can fit it in with that, I think.
I think, quite honestly, the workforce group, we've not managed to get the kind of buy-in for that I would like to have seen. I think it ought to be brought back into the main work plan, might I suggest?
Yeah, I think you're right there. I think we'll have to arrange that, won't we, outside of this meeting. So, okay, so there's no more questions, I think. So thank you to Sarah and Kirsty for coming along. That was an interesting item as well. And we'll no doubt see you soon.
Thank you.
Thank you.
Okay, Mike, are you still there? No, Mike's got to go, haven't you, shortly? So
I'm still here, Councillor.
Right, okay.
So on are we on the work plan? Sorry, I was.
Yeah.
Well, I think if I may, Chair, we've already agreed, or you've already agreed, that you want to have an item on dentistry at a previous meeting, and I've talked to Ian Holmes about arranging that for a meeting in the new year. We talked about having a meeting in January to look at the governance issues. If I may, can I suggest that we have some discussions outside the meeting about this? I also need to add and give an apology to the committee that there was a deputation that seems to have got missed, probably by me. So my responsibility from I can't remember who it's from. I'll tell you in a second. But it was around it was about the Constitution, and it was from Christine at North Kirklees NHS Support Group, and I'll circulate it to members, but effectively the headline is, we think the IC board membership should be broader to include the public, trade unions and the vital but overlooked clinical services, NHS dentistry and NHS maternity services. Several aspects of the draft Constitution section on integrated board membership arrangements need clarification. There's more detail in it, and I'll circulate that to members of the board, but I thought I should mention that so that it's actually recorded in the minutes that we also had. Christine Hind? I can't quite remember. Yeah, Councillor Smage is nodding. So that's all I want to say under the work plan, and I do need to leave very shortly, Chair.
That's sorry. Fine. I think we're pretty much finished now, aren't we? But I'd like somebody to write in and say we'd like elected members to have representation on that board, but nobody's going to do that, are they? Right, okay, so I think that's the end of the meeting, unless there's anything anybody else wants to say. We'll circulate some dates around about our sort of informal meeting about the ICB, if that's okay. And Councillor Hutchinson will have a chat about reigniting the workforce group, I think.
I think somebody needs to set a fire underneath them.
Yeah.